Welcome back, guys. Now in this video we'll be discussing about the rapid revision of endocrine physiology. So in this session let's try to integrate as much as possible from the patho as well as from the medicine. How I will be going in this session is I will be mainly discussing from the PYQ. So I will take a PYQ and I will go around the topic. Okay, so what and all the important topics which are needed from the endocrine physiology. So every time definitely you are going to get 2-3 MCQs, okay, directly and indirectly from this topic, okay, from this endocrine physiology. Having said that, without any further late, let's begin the topic. So first MCQ, look here, identify the hormone from this picture. Okay, so there is this one hormone which is fluctuating. For example, look here, during daytime, okay, let me draw, during daytime, see the amount of the hormone is less, and after taking the meal, look here, after taking the meal the hormone is rising, after exercise again it is rising, and during sleep its level is high, its peak. So what is this hormone which is going to increase after eating, after exercise and during sleep? What is this hormone? What do you think? Is it cortisol, is it estrogen, or is it insulin? Okay, after eating, you know, insulin levels will be high, okay, but insulin levels are not going to rise during sleeping, right? So definitely insulin is not the answer, because insulin level will not rise during the sleep. And estrogen, you know, the highest levels of estrogen will be seen, okay, during the first 14 days of the menstrual cycle. During the first 14 days of the menstrual cycle, you know, the estrogen levels will be high, and on the 13th day or just before the ovulation, there will be high levels of estrogen, and the high levels of estrogen is going to stimulate the release of LH. Okay, there will be LH surge. Okay, high levels of estrogen will stimulate the release of LH, and LH is going to cause the ovulation. So estrogen levels are not going to fluctuate in a day. Okay, estrogen levels will not increase after exercise, will not increase after eating, will not increase during sleep. No. Okay, so estrogen is not the answer. So cortisol, let's talk about the cortisol. See, cortisol levels, cortisol is a one hormone which shows bimodal distribution, or I should say diurnal variation. So what exactly is this diurnal variation? So diurnal variation means sometimes in a day its level is going to be very high, and sometimes during the day its level is going to be very less. Okay, you know, cortisol is a stress hormone. It's going to show the diurnal variation. 4 AM in the morning. Okay, do you think, are you going to have any stress? No, you are absolutely sleeping. You are very happy, you are sleeping in the deep sleep, no stress in the body. So cortisol levels are going to be damn low. So lowest levels of cortisol, low levels of cortisol is going to be seen in the 4 AM in the morning. And when you wake up and when you are getting ready to go to your work, okay, to go to your work, again work is kind of a stress. So what happens is somewhere around 8 AM in the morning, okay, 8 AM in the morning, there will be high levels of cortisol. So certain times in a day, the cortisol levels are going to be low, and certain times in a day, cortisol levels are going to be high. This is called as a diurnal variation. So diurnal variation is shown by cortisol. Okay, so cortisol levels are not going to increase after meal. They are not going to increase during the sleep. No. So cortisol is not the answer. So what is the answer here? The answer here is growth hormone. So remember, growth hormone is one thing, okay, one hormone which is going to increase after sleep, after eating, and after exercise. So let me write it here, important points regarding the growth hormone. You know, growth hormone, what kind of hormone it is? It's anabolic hormone. Okay, anabolic hormone. Now tell me, if it's an anabolic hormone, what is it going to do with the protein synthesis? What is going to do with the carbohydrate metabolism and fat metabolism? Look, growth hormone, it increases the blood glucose levels. Remember, this is the important point. It's a glucogenic hormone. Okay, it increases the blood levels of glucose. Okay, no doubt in that. What about the protein metabolism? It's an anabolic hormone. It bulks up your body. It's going to increase in the muscle mass. So proteogenesis. Okay, it's going to cause the proteogenesis. Okay, and what about the fats? Lipolysis. Okay, it's going to cause the lipolysis. So these 3 points, growth hormone, anabolic hormone, it's going to increase the blood levels of glucose and helps in the proteogenesis, and lipolysis is going to give you a better shape of the body. Growth hormone, right? See, when do you think these growth hormone levels are going to increase? I always think, when I was a student, I always used to remember, see, growth hormone, it increases the glucose levels. So any condition, remember, any condition where you require the glucose, in that condition growth hormone levels are going to be increased. Okay, for example, say during fasting. Okay, during fasting, do you require glucose or not? Yes, you require glucose. Growth hormone increases the glucose. Okay, during fasting, which hormone is produced in your body? Ghrelin. Okay, ghrelin increases the growth hormone increases the glucose. So in which conditions growth hormone levels are going to increase? 1, fasting. Next, ghrelin. Next, exercise. Okay, exercise. Now, okay, exercise. You know, during exercise you require the glucose. So who can increase the glucose? Growth hormone increases the glucose. Next, trauma. Okay, it can be any trauma. It can be psychological trauma, emotional trauma, or like physical trauma, where you are having a repair in your body. Okay, microbiological trauma means you have to repair your body. After trauma, you have to repair. For repair, you require the glucose. For taking a better decision, for example, you are having a trauma, emotional trauma, you have to take a better decision. For that, you require the glucose so that you can take a better decision. So, in all the traumatic conditions, or you can say stress. Okay, so growth hormone levels increases. Okay, growth hormone level increases. The better word is trauma rather than writing stress. Stress might unnecessarily confuse you. So, trauma. So, fasting, ghrelin, exercise, trauma. Next, eating. Okay, so eating, if you eat amino acid which is called as arginine will be released. This arginine also stimulates the release of growth hormone. It also increases the levels of growth hormone, because arginine is amino acid. When amino acids are coming into your body, what you have to do? By using that amino acids, you have to produce the proteins. So when you eat, amino acid level increase in your body. So amino acids are giving signal to the growth hormone. Like, growth hormone, please come. So growth hormone is helping in the protein synthesis. Okay. Next, eating completed sleep. Especially with sleep, NREM stage 3 and 4, that's a deep sleep. During deep sleep, NREM stage 3 and 4, growth hormone level increases. Not only them, also estrogens and testosterone. Estrogen. So what exactly are they? Sex hormones. Even the sex hormones increase the blood levels of glucose, okay, and blood levels of growth hormone. So the point which I want you to know is, in which conditions, in which of the following conditions growth hormone increases? Okay, so fasting, ghrelin, exercise, trauma, eating, sleep, testosterone and estrogen. These are the conditions where growth hormone levels are going to increase. Okay. Next, if someone asks you where exactly growth hormone levels are going to go down, when growth hormone levels goes down, okay, that is somatostatin. Okay, somatostatin decreases growth hormone, you know it. And not only that, insulin like growth factor, ILGF, okay, insulin like growth factor 1 or somatomedian C. Okay, somatomedian C decreases the growth hormone. Okay, can you tell me one pharmacological drug which decreases the growth hormone? Okay, the one who can decreases the growth hormone production means octreotide, somatostatin analogs like octreotide. Okay, octreotide, lanreotide, they also decrease the growth hormone production. So in this one question, what I have discussed is the conditions where the growth hormone levels are going to rise and the conditions which can decrease the growth hormone levels. Okay, done. Next question, inhibin, it is secreted by. Okay, inhibin is secreted by. See, for that you need to know the axis, hypothalamo pituitary gonadal axis. Now inhibin, I am talking in the male. Okay, inhibin is also produced in the females, inhibin is also produced in the males. Now, right now I am talking about the males. So this is the hypothalamus. Okay, here is the hypothalamus. Down to the hypothalamus, what do we have? Here is the pituitary gland. Okay, here is the pituitary gland. I am talking about the anterior pituitary right now. And here is the gonad. You know, what is the gonad that is present in the males? It's the testis. Testis is present. Okay, in the testis, how many types of cells are there? There are Sertoli cells. There are Sertoli cells and there are interstitial cells of Leydig. Okay, there are interstitial cells of Leydig, Sertoli cells and interstitial cells of Leydig. Now in male, see what exactly is happening. This hypothalamic nucleus, okay, the hypothalamic nucleus is going to produce GnRH, gonadotropic releasing hormone. These gonadotropic releasing hormones are going to act on gonadotropes. Now what does these gonadotropes do? The gonadotropes are going to produce FSH in males and even LH. Okay, FSH and LH. Now see, this FSH is acting on which cells? FSH is acting on Sertoli cells. Now when the FSH is acting on the Sertoli cells, now the Sertoli cells produce inhibin B. Okay, inhibin B. Now when the LH is acting on the interstitial cells of Leydig, see, remember L for L. Okay, L for L. LH is acting on Leydig cells. Now these interstitial cells of Leydig, they are going to produce testosterone. Okay, they are going to produce testosterone. Okay, testosterone. Now here the important questions which I want you to know is, see, which cell is producing the inhibin B? It's a Sertoli cell. Okay, it's a Sertoli cells. Leydig cells produce testosterone. Now look at this testosterone. This testosterone is not a potent form. It's not a potent form. The testosterone will be acted upon by an enzyme called as 5-alpha reductase. Okay, 5-alpha reductase. Now when the testosterone is being acted upon by the 5-alpha reductase, it will be converted into dihydrotestosterone. Okay, it's the most powerful androgen. It's the most potent androgen, dihydrotestosterone, DHT. Okay. Now for your exam, the points which I want you to know is, this dihydrotestosterone is the one which is responsible for certain pathological conditions or some abnormalities. Like in males, you know, in 60-year-old male, maybe he is suffering from a problem called as benign prostatic hyperplasia. So it's the high levels of dihydrotestosterone. It's the high levels of dihydrotestosterone which is responsible for benign prostatic hyperplasia. And it's the dihydrotestosterone which is responsible for male pattern baldness. Male pattern baldness. Okay, so just remember, it's the dihydrotestosterone, not the testosterone. It's the dihydrotestosterone which is responsible for benign prostatic hyperplasia, MCQ, and male pattern baldness. Now I'm just trying to integrate a little bit more here. See, once you have inhibin B, what this inhibin B is going to do? Remember, till the time of your exam or lifelong, remember, wherever you see the word inhibins always give negative feedback to FSH. Okay, the testosterone will give negative feedback to LH. And who gives the negative feedback to FSH? It is inhibin, negative feedback. Okay, negative feedback. Okay, so this is what happens in the male. So now tell me, in male, Leydig cells, it's the Leydig cells which produce testosterone, Sertoli cells produce inhibin, and interstitial cells, okay, these are nothing but the interstitial cells of Leydig producing the testosterone. And PEG cells, see, the PEG cells are present in one of the FMGE exam, this question was there, PEG cells, they are present in the fallopian tube, whose function is not yet known. So PEG cells are present in the female reproductive tract, it is a fallopian tube. Okay. Now I just want to add a few more points here. What about the females? Okay, if I am just discussing about males, females will be not happy. Okay, they might think I am showing partiality. So let me discuss a few more important points about the females. Okay, so hypothalamus, even females have hypothalamus. They do have the anterior pituitary, but their gonads are different. Okay, their gonads are ovaries. Okay, here are the ovaries. Now look carefully here. In female, this hypothalamic nucleus, it is producing GnRH, gonadotropic releasing hormone. So releasing hormones. Okay, in one of the FMGE exam, this question was there, releasing hormones, gonadotropic releasing hormone, corticotropic releasing hormone, thyrotropic releasing hormone, growth hormone releasing hormone. Releasing hormones are produced by hypothalamus. Okay, releasing hormones are all produced from hypothalamus. Okay, just a point. So let's talk about the females now. Now this hypothalamic nucleus, it is producing the GnRH, gonadotropic releasing hormone. It acts on which cells of anterior pituitary? Gonadotropes. Now these gonadotropes are going to release FSH and LH. So what is the function of this FSH? What is this FSH doing in the female? In the name itself, it's a follicle stimulating hormone. Okay, it stimulates the follicles. Okay, it stimulates the follicles. For example, say in a female ovary, there are these follicles present. Okay, there are these follicles present. Look here, I am showing you one follicle. Here is the oocyte. Okay, this is the oocyte. This oocyte is surrounded by some cells. Okay, these oocytes, they are doing what? They are surrounded by some cells. Here the red color cells, and these red color cells are further surrounded by these blue color cells. Let me show you blue color cells. These are the follicles. Here I am showing you one follicle. Okay, this is not a sunflower or kind of thing. This is a follicle. So in the center, what is there? In the center, this black color thing which I am showing here, this is the oocyte. Okay, it's a oocyte. Oocyte is surrounded by cells. So this red color cell, here I am showing you, this is called as a granulosa cell. Okay, this red color cell which I have shown here is a granulosa cell, and this blue color cell is called as a theca cell. Okay, it's called as a theca cell. Now listen carefully. It's a follicle stimulating hormone. See, the follicle stimulating hormone is coming and acting on this follicle. Follicle contains oocyte, granulosa cells and the theca cells, right? Now this FSH, follicle stimulating hormone, it's coming and acting on these follicles. Okay, these follicles. Which part of the follicle especially? It is going to act on the granulosa cells. Okay. So FSH is acting on which cells? FSH is acting on granulosa cells. So let me write here, FSH is acting on the granulosa cells. Now these granulosa cells is going to produce estrogens. Okay, now the granulosa cells produce estrogens. Okay. Now, what about this LH? In female, LH. What about the LH? Going in the females. Okay. Later I will explain you the functions of the LH. But for now, remember, FSH is acting on the granulosa cell. Okay, FSH is acting on the granulosa cell. Granulosa cells produce estrogens. Okay. Now, then what about the function of the theca cells? What do these theca cells do in the females? Actually, the theca cells are acted upon by LH. Okay, the LH is acting on the theca cells. Okay, so the theca cells are going to produce androgens. Okay, so remember, in females, androgens are produced from which cells? It's a theca interna cells, MCQ. Theca interna cells. If the theca interna cells produces the androgens, these androgens, they will go into the granulosa cells. The androgens will go into the granulosa cells. Okay, the androgens will go into the granulosa cells. The testosterone goes into the granulosa cells. In the granulosa cells, okay, with the help of enzyme called as aromatase. Okay, with the help of enzyme called as aromatase, the androgens will be converted into estrogens. Okay, so this is the important point which I want you to know. In a follicle, there are two types of cells present. One is the granulosa cell, other is the theca cell. Okay, so it's the LH. Remember, it's the LH which stimulates the theca cells. LH stimulates theca interna cells. Now the theca interna cells are producing androgens. Where do these androgens go? Androgens go into the granulosa cells, where they are getting aromatized with the help of aromatase enzyme, so that estrogens are getting produced. So what is the function of estrogens in the female? Now tell me, what is the function of estrogens? Estrogens are helping in breast development. Okay, breast development. And the estrogens, they will go to the uterus. They will go to the uterus and helps in the growth of endometrium, that is endometrial proliferation. Okay. So the two functions of the estrogen, breast development and endometrial proliferation, which I want you to know. Again and again I am telling you, FSH helps in the production of estrogens. FSH helps in the production of estrogens. Okay. LH, you know, okay, I don't want you to go into the in-depth. Okay, LH acts on theca interna cells. Theca interna cells produces androgens. That's a question. Okay. Androgens will be converted into estrogen with the help of enzyme aromatase. Done. Point is, I can say something like this. FSH helps in the production of estrogens. Okay, FSH acts on granulosa cells. So granulosa cells will convert the androgens into estrogens, and estrogens are getting released. So I can say something like this. FSH helps in the production of estrogens. So once you have estrogens, what do these estrogens do? Estrogens give negative feedback. Okay, estrogens, what do they do? Estrogens give negative feedback. Okay, to the FSH. Negative feedback to FSH. And not only that, okay, not only that, these granulosa cells, okay, granulosa cells, they also produce inhibin. Okay, they also produce the inhibin. What is, wherever you see the word inhibin, inhibin also gives negative feedback to FSH. Okay. Next, what else I want you to know is, see, then what is the function of LH? You know, one function of LH is the production of androgens, and that's okay thing. Okay. Now, because of this FSH, follicle stimulating hormone, it's the follicles are getting stimulated. The follicles will grow actually. The follicles will grow. Okay, the follicles are growing. When the follicles are growing, okay, to their maximum size, now you are having the matured follicle. So now what you have is, by the mid of the cycle, you are having matured follicle. Okay, so this matured follicle is called as Graafian follicle. See, now you are having a matured follicle that is called as a Graafian follicle. Now who is going to act on this Graafian follicle? It's the LH. Now LH acts on this Graafian follicle, so the Graafian follicle will be ruptured. Again, now it will be ruptured. Graafian follicle is going to be ruptured. Now once Graafian follicle is ruptured, oocyte will be released. Okay, now what you are having is the secondary oocyte. So secondary oocyte will be released. So can I say something like this? What is exactly this process called as? See, LH is acting on the Graafian follicle, so causing the rupture of the Graafian follicle. So the secondary oocyte is released. The whole process is called as ovulation. Okay, the whole process is called as what? Ovulation. So LH helps in the ovulation. So now what happens to this ruptured follicle, ruptured Graafian follicle? Now Graafian follicle is there, it's ruptured, it's releasing the oocyte. Now what happened to this ruptured Graafian follicle? Okay, for example, let's say here is a follicle which is ruptured. It is releasing what? It is releasing the oocyte. Okay, it is releasing the oocyte. Now this ruptured Graafian follicle, again, it is made up of granulosa cells only. These are nothing but the granulosa cells, but it's a ruptured follicle. Okay, this is called as corpus luteum. Okay, this is called as what? Corpus luteum. Now what does this corpus luteum is going to produce? Corpus luteum is going to produce progesterone, a smooth muscle relaxant which keeps the uterus in a relaxed state for the 9 months. Okay, progesterone, progestational hormones, it's going to make the secretory changes in the endometrium. Okay, what it does, progesterone? Secretory changes in endometrium, which is more favorable for the implantation, of the embryo. If at all there is a pregnancy, if there is an embryo, that will be more favorable. Okay, so secretory changes in the endometrium, one thing, progesterone it does. And not only that, this progesterone, say, from where it is coming? Who is responsible for the release of the progesterone? The progesterone is there because of the ovulation. And why there is ovulation? Because of the LH. So LH is the one which is responsible for the ovulation. Remember, LH is the one which is responsible for the ovulation and progesterone production. So this progesterone, what it does is, it gives negative feedback. It gives negative feedback to LH. So I can say two things. FSH is getting negative feedback from estrogens. FSH is getting negative feedback from estrogens, also inhibit, no doubt. LH is getting negative feedback from where? Progesterone. So progesterone gives negative feedback to LH. Okay, and these are the points which I want you to know. So in one of the exam I have seen, inhibin B is produced by, inhibin B is produced by, it is, for example, say inhibin B is produced from the Sertoli cells. From where inhibin A is getting produced? This was the question which was asked. This corpus luteum, it not only produces the progesterone, it also produces inhibin A. Okay, corpus luteum produces inhibin A. And not only that, even placenta produces inhibin A. So these are all the MCQs, okay, which I want you to know. Any question can be there in your exam. Okay, so this progesterone is going to give the negative feedback. Progesterone is the one which makes the endometrium secretory. Okay, which makes the endometrium secretory. And who produces the inhibin A? It's the corpus luteum produces progesterone as well as inhibin A, and placenta also produces the inhibin A. Wherever you see the word inhibin A or inhibin B, doesn't matter. Inhibin always gives negative feedback. Okay, inhibin always gives negative feedback to FSH. Okay, done. So with this, the important points which I want you to know regarding the hypothalamo pituitary gonadal axis is completed. Okay, now let's look at some questions. Testosterone, by this time you should tell me, testosterone is produced by mainly which cells? Interstitial cells of Leydig. Okay, it's the interstitial cells of Leydig produce the testosterone, Sertoli cells produce inhibin. Okay, inhibin. And what are the important points about the seminiferous tubules? Seminiferous tubules are the places where the spermatogenesis is happening. Okay, spermatogenesis is happening, and epididymis. Epididymis is a place where, okay, sperms are stored and they acquire motility. Okay, sperms are acquiring motility. Where the sperms are going to acquire the motility? In the epididymis. These are some important MCQs. Next, image shown below depicts which of the following types of cell signaling. In endocrine, actually we start the endocrine physiology with this basic topic. See here, now I am showing you cell 1, cell for example A, this is the cell B. Now cell A is producing certain chemicals. Okay, certain chemicals are getting produced. These chemicals are acting on the nearby cell. Okay, these chemicals are acting on the nearby cell. So one cell is communicating to the adjacent cell, just side by cell. I am just talking to my friend, imagine. Okay, something like this. So this type of signaling, this type of talking between the cells is called as paracrine signaling. Okay, para means side or adjacent. If one cell is producing some chemical and that chemicals are acting on the surrounding cell, maybe those chemicals might be stimulating or maybe they are inhibiting, doesn't matter. So if a one cell is communicating to the other cell, just adjacent cell, that is called as a paracrine signaling. Now let me show you, look here, I am showing you this is one cell, it is producing certain chemicals and those chemicals are acting on the adjacent cell. So what kind of signaling it is? It is a paracrine signaling. Then what is autocrine? Auto means self. Okay, auto means self. So here one cell, okay, here one cell, it is producing certain chemical substances, maybe a hormone or something. Okay, they are coming back and acting on the same cells. Maybe they are stimulatory or maybe they are inhibitory. Okay, for example, this is mainly seen with the T cells. Okay, mainly seen with the T cells. They are releasing certain cytokines. Those cytokines are coming back and acting on the same cells. Okay, such kind of signaling is called as autocrine signaling. Auto means self stimulation. Okay, next, what is endocrine signaling then? Endocrine signaling means, see, these are cells, they are releasing certain chemicals or cytokines or hormones and they are directly entering into the blood, they are released into the blood. Now they are traveling within the blood and they are coming and acting on some distant cells. Okay, they are coming and acting on some distant cells which are present somewhere far. Okay, these hormones are traveling within the blood. So this is called as endocrine signaling. Look, hormones secreted into bloodstream. So in which type of signaling the blood vessels are involved? Hormone. Okay, that's endocrine signaling. Okay, so these three image based questions might show up in your exam like autocrine, paracrine and endocrine signaling. So better know for it, know for the exam. Now hormone involved in the milk secretion, the famous question repeatedly asked. Okay, so hormone involved in the milk secretion. I just don't want to tell something like just like that. Look, you need to know from the basics. Here is the female's hypothalamus. Let's say this is the female's hypothalamus. Here is the anterior pituitary. Now in the anterior pituitary there is a cell. This is called as a lactotrope. Now what is the name of it? Lactotrope. Okay. Now these lactotropes, they will produce prolactin. Okay. Now where do this prolactin will come and act? Prolactin will come and act on the breast tissue. So what this prolactin is coming and doing? Prolactin is coming and acting on the breast tissue. So what the breast is going to produce? The breast is going to produce the milk. So that is called as milk production or lactogenesis. Okay, milk production or lactogenesis. Okay, lactogenesis, milk production. But before that, first of all, you have to have a breast. Okay, first of all, you need to have a breast. So when a female is during her puberty, when a female is in her puberty, the breast tissue is getting produced. The breast is getting produced, and you know by this time already. So who is helping in this process of mammogenesis? So who is helping in the mammogenesis, development of the breast? It's the estrogens. I have told you estrogens function is the breast development. Estrogens. Okay, estrogens helps in mammogenesis. Now milk is produced. Okay, milk is okay. For example, let's say the milk here. let's say here is a milk. Okay, in the breast, lot of milk is there. Production is with the help of prolactin. Okay, that milk should come out. Okay, production completed. That milk should come out. So who is helping in that process? It is oxytocin. Okay, so let me write here oxytocin. Oxytocin hormone, which is coming from the posterior pituitary. Okay, so posterior pituitary actually it stores the oxytocin. So whenever there is a time, I will explain you whenever there is a time, whenever there is a need, the posterior pituitary is going to release oxytocin. What oxytocin is going to do? Oxytocin is going to act on the breast. So when oxytocin is acting on the breast, what happens? Milk is going to come out. Milk is coming out. Okay, milk is coming out. So this is called as, okay, let me draw it with a darker color, so it will be better for you. For example, let's say, so milk is coming out. So this is called as milk ejection. Which is also called as galactokinesis. Okay, galactokinesis. So tell me, who is the hormone which is responsible for the galactokinesis? Oxytocin. Okay, oxytocin is responsible for galactokinesis. Who is helping in the production? Prolactin. Okay, lactogenesis. Lactogenesis is with the help of prolactin. Lactokinesis or galactokinesis is with the help of oxytocin. Mammogenesis is with the help of estrogens. Okay. Now, you might be thinking, why I am discussing all this is because in the recent FMGE exam, this question was there. They have asked you to arrange the things in the order. Okay, arrange the things in the order. Okay. First, there should be mammogenesis. There should be mammogenesis. Later, the next step is lactogenesis. Next, galactokinesis. Sorry. Yeah, galactokinesis. And it should be maintained, the milk production and let out. Okay, milk production and milk ejection. Okay, milk production, milk ejection. It should be maintained. So maintenance of this process is called as galactopoiesis. Okay, so galactopoiesis is the last step. So this is the order which I want you to know. Mammogenesis with the help of estrogen. Next, lactogenesis is with the help of prolactin. After lactogenesis, there should be galactokinesis. After galactokinesis, there should be galactopoiesis. The maintenance, remember, maintenance. Okay. So these are some important points which I want you to know for your exam. Order. So now tell me, hormone involved in milk secretion. Okay, hormone involved in milk secretion. It is prolactin. Okay, prolactin is helping in the milk secretion, or you can say milk production. Okay, not milk ejection, milk secretion ke liye you require prolactin. But what else I want you to know is, let me add here a few more concepts. See, imagine this is the female's hypothalamus. Okay, here I am talking about the female, the hypothalamus. This is the hypothalamus. Look carefully. Here there is a nucleus. Okay, let's say something like this. Here is anterior pituitary. Now there is a cell. What is the cell? Lactotrope. Now I am asking you, let's say this is a 15-year-old female, or let's say 20-year-old female. Okay, she is 20 years or 21 years, for example. Now I am asking, does she have hypothalamus or not? Yes. Does she have anterior pituitary or not? Yes, anterior pituitary is there. Now does she have breast tissue or not? Even breast tissue is there. Okay, even breast tissue is there. But why she is not lactating? Okay, why she is not lactating? Is because, say, normally before the delivery of the baby, see this hypothalamic nucleus, there is a hypothalamic nucleus. It releases something called as dopamine. Okay, what is it releasing? Dopamine. Okay, a very, very important concept for your exam. So this hypothalamic nucleus is releasing dopamine. What this dopamine will do before the delivery, before delivering the baby? Okay, this dopamine is inhibiting. Okay, what this dopamine is doing? Dopamine inhibits the lactotropes. So lactotropes are inhibited. These lactotrope, it is inhibited. Okay. So now do you think prolactin will be produced? No, there is no prolactin, it is inhibited. So no prolactin. So from this, the question which I want you to know for your exam is, what is the antagonist of prolactin? So dopamine is the antagonist of prolactin. So dopamine is antagonist of prolactin. Okay. So what dopamine will do? Dopamine decreases the milk production. For example, if the patient is having abnormal milk production, that is called as galactorrhea. Okay, abnormal milk production. So unnecessarily milk is getting produced. So what is the drug that you have to use? You have to use dopamine. So for galactorrhea, you can use dopamine or dopamine agonists or dopamine agonists. Okay, dopamine receptor agonists like cabergoline. Okay, dopamine receptor, they will go and stimulate the dopamine receptors. They will inhibit the milk production because they are like dopamine. They are dopamine agonists. Cabergoline is a drug of choice for galactorrhea. Okay, cabergoline or bromocriptine. Okay, cabergoline, bromocriptine, and what else you can use? Cabergoline, bromocriptine, or dopamine directly, or dopa, levodopa. So you might be thinking why I am giving all this information is because in one of the exam they will ask you, in one of the exam they have asked which of the following drugs are all of the following drugs. All of the following drugs can be used in the treatment of galactorrhea. Okay, you can use cabergoline. Why? Because it is a dopamine receptor stimulant. It acts like a dopamine. Bromocriptine same. It acts like a dopamine. You can use the dopamine or L-dopa in the body. Levodopa will be converted into dopamine. So all these drugs can be used in the treatment of galactorrhea. Okay. So these are the concepts which I want you to know. What is the physiological antagonistic of dopamine? It's prolactin. What is the physiological antagonist of prolactin? It is the dopamine. Dopamine decreases the prolactin levels. Okay, dopamine decreases the prolactin levels. Now, here itself, I want you to tell one thing, okay, as an integration. Look here. See, here is the hypothalamus. Let's say hypothalamus. Here is the anterior pituitary. Okay. Now, there is a condition which is called as Sheehan syndrome. Okay, there is a condition called as Sheehan syndrome. What happens in the Sheehan syndrome is, look, the whole pituitary gland is dead. Okay, the whole anterior pituitary is dead. So all the cells in the anterior pituitary are dead. For example, let's say cell number 1, first cell. There are many cells in the pituitary gland, you already know it. So for example, let's say the somatotropes. Lactotropes. Thyrotropes. Corticotropes. Gonadotropes. So all the cells are dead. All the cells are dead. So there is a condition called as Sheehan syndrome. Why that Sheehan syndrome will occur, I will explain you. So in this Sheehan syndrome, okay, let me first explain. What happens is, there is a female, okay, who is a pregnant female. What she had is a postpartum hemorrhage. Postpartum hemorrhage. Now whenever there is a postpartum hemorrhage, so she is bleeding, lot of bleeding. So what happened to his blood volume? Blood volume decreases. Her blood volume decreases. So when her blood volume is decreasing, to maintain the BP, there will be severe vasospasm. There will be severe vasospasm in her body. Because of the severe vasospasm, there will be less blood flow to all the parts of the body, also to the less blood flow to the anterior pituitary. There will be less blood flow to this anterior pituitary. Blood is not properly going to the anterior pituitary. Okay, actually during pregnancy, pituitary gland increases in size. During pregnancy, pituitary gland is increased in size. It requires more blood flow, it requires more oxygen. But what is happening now? This female who is having postpartum hemorrhage, okay, unfortunately she had postpartum hemorrhage and her blood volume is losing, she is losing the blood volume. So what happens? There will be severe vasospasm. Okay, now she is going into shock. Okay, now she is going to shock. So what happened to the blood flow to the organs? What happened to the perfusion? Decreases. Blood flow to the pituitary gland decreases. So the entire pituitary gland is now dead. All these cells in the pituitary gland are dead. So when the somatotropes are dead, what happened to the growth hormone production? Growth hormone production decreases. When lactotropes are dead, prolactin levels decrease. Thyrotropes, when they are dead. So what happened to the TSH? Decrease. What happened to corticotropes? ACTH levels decrease. What happened to gonadotropes? GnRH levels decrease. So all levels decrease. All levels. So tell me, in Sheehan syndrome, what's the main problem? There is postpartum hemorrhage. That postpartum hemorrhage is leading to necrosis of the pituitary gland. Okay, so it's called the postpartum necrosis of pituitary gland. Okay, it's a postpartum necrosis of pituitary gland. So what happened to all the hormones? All hormones decreases. Also prolactin. Now, actually she is a pregnant lady, right? She is a pregnant lady. She have delivered the baby. After delivering the baby, she had a complication, okay, postpartum hemorrhage. But luckily she is in a good hands. Okay, her postpartum hemorrhage is controlled later. Okay, her postpartum hemorrhage is stopped. So she survived. Luckily she survived. Everything is good. But what happens is, look, her pituitary gland is dead. Her pituitary gland is dead. The lactotropes are not present. So prolactin is not there now. Without prolactin, she can't lactate. So her main problem is going to be immediately there is failure to lactation. So there is failure to lactation. So that's the main problem. So whenever you see this failure to lactate, pregnant female, she had a complicated delivery of postpartum hemorrhage. Following that, she had a problem with the failure to lactation. Think about which syndrome? Sheehan syndrome. Sheehan syndrome. Okay. Now, after Sheehan syndrome, the next point which I want you to know here itself is there is a chance that you can get a question from Sheehan syndrome, and also you can have a clinical based question, something like this. See, here is a hypothalamus. Now what is this? This is the pituitary gland. Now here is a pituitary gland. Now what happened here? Look, the pituitary gland is separated, okay, because of some trauma, because of some accident, or because of whatever the reason. The pituitary gland, it is separated. So there is damage to pituitary stalk. Whenever there is a damage to pituitary stalk, now this entire pituitary gland is still living. Remember that point. It is having its own blood supply. It is living. There is no death. Okay, hypothalamus is okay, pituitary gland is okay, but there is a connection lost. There is a connection lost. So what happens? Whenever there is a pituitary stalk damage, all hormone levels, all the hormones from the anterior pituitary, they decrease. All hormone levels decreases. Okay, all the hormone levels decreases. That is growth hormone levels. Okay, you know, no need to write it again. Growth hormone levels, FSH, growth hormone, FSH, LH. Okay, all the hormone level decreases. Okay, the one point which I have made here, this is not GnRH, this is FSH, LH. FSH, LH. Okay, here also this is not ACTH. ACTH is coming from hypothalamus. Here it should be CRH. Okay, sorry, this is correct only. ACTH. There is no doubt. ACTH. Okay, there is no problem with ACTH. Just confused. Yeah, the TSH is going down, ACTH is going down, FSH and LH are going down. It's not the GnRH. Actually, GnRH comes from the hypothalamus. Okay, done. Now, look here. Whenever there is a damage to the pituitary stalk, all the hormone levels decreases except prolactin. Prolactin level actually increases. Prolactin level increases because I have told you it is the hypothalamic nucleus which produces the dopamine. What this dopamine will do? Dopamine will come down and dopamine inhibits lactotropes. Okay, what the dopamine will do? Dopamine inhibits the lactotropes. So lactotropes, they don't produce prolactin. But what happened now? See, the dopamine is unable to come down. Okay, dopamine is not coming down. Okay, directly dopamine is not coming down. So now do you think there will be inhibition? There is no inhibition. Now there is no inhibition. Whenever there is no inhibition, what do lactotropes do? Lactotropes are going to produce prolactin. Okay, so whenever there is a damage to pituitary stalk, all the hormone levels decreases except prolactin. Okay, and in Sheehan syndrome, all hormone level decreases, also prolactin. Now, tell me, what is the order? What is the order of milk production? Order. What should be mammogenesis? Next, lactogenesis or lactopoiesis, milk production. Next, galactokinesis, milk ejection, and galactopoiesis. Galactopoiesis means maintenance. Okay, can you tell me what is the hormone which is antagonistic of prolactin? Dopamine. Can you tell me any drug which is a dopamine agonist? Bromocriptine and cabergoline. Okay, so now next let's see this question. Which of the following condition prolactin levels are going to be highest? When you see highest levels of prolactin, you know prolactin is going to help in the milk production. So in the given options, prolactin levels are going to be seen highest 24 hours after delivery, because you know 24 hours after delivery what mother is doing? Mother is lactating. Okay, you require prolactin. So this is the answer. Okay. Next, upon cervical stretch, uterine contractions and delivery occurs. Okay, which of the following shows similar mechanism of action? See, when you stretch the cervix, okay, actually you are not stretching the cervix. The baby, okay, as the baby is growing and growing, okay, in the uterus the baby is growing. 30 weeks, 35 weeks, 37 weeks, the baby is growing, the head circumference is increasing. Now the baby's head circumference is increasing and the baby is descending also. When the baby is trying to descend, what happened to the cervix? The cervix is gradually getting stretched because of the growth of the baby. The cervix is getting stretched. When you stretch the cervix, immediately do you know what happens? Oxytocin will be released. How exactly that happens? With the help of a reflex called as neuroendocrine reflex. Look at here. Here I am showing you, guys, here you are stretching the cervix because of the baby. Okay, because of the baby, you are stretching the cervix. The stimulus is stretch of the cervix in the late pregnancy. Now the stretch, this information, look where it is going. This information through the neurons. So with the help of the sensory neuron, this is going to hypothalamus. That cervix is getting stretched. Now this is the time to kick the baby out. So hypothalamus, see what it is doing. So hypothalamus, it is giving signal to the posterior pituitary to release the oxytocin. So immediately oxytocin will be released. So what oxytocin will do? You know, oxytocin causes the contraction of the uterine smooth muscles. So when the uterine smooth muscles are contracting, the baby will be delivered. Okay, the baby will be delivered. So here, this reflex which I have shown you, this is called as a neuroendocrine reflex, because one limb, okay, the afferent limb, see that is a neural, okay, afferent limb, the information is going through the neurons, and efferent, okay, the response limb is coming in the form of a hormone. So this is endocrine hormone, oxytocin released into the blood. So this is example of a neuroendocrine reflex. Stretching the cervix releases the oxytocin, neuroendocrine reflex. Okay, any similar reflexes are there in the body, same neuroendocrine reflex? Yes, example, say when the baby is latching onto the nipple, okay, when the baby is latching onto the nipple and the baby is sucking the nipple. Now when the baby is sucking the nipple, this information, where is going? This information is again going to the hypothalamus. Okay, so now what hypothalamus will do? Hypothalamus stimulates the posterior pituitary to release oxytocin again. Now what this oxytocin will do, you know already. Oxytocin help in milk ejection, milk let out, galactokinesis. So immediately the myoepithelial cells are going to contract and there will be milk ejection. So one limb, okay, this limb is a neural and the efferent limb or the response limb is with the help of a hormone. Okay, so this is also an example of a neuroendocrine reflex. So in your body, there are two neuroendocrine reflexes. What are they? Cervical stretch, oxytocin. Sucking the nipple, oxytocin. So these two are the examples of a neuroendocrine reflexes. Okay, now based on this, now tell me, what is the answer? Upon cervical stretch, uterine contractions and delivery occurs. Which of the following shows similar mechanism of action? Milk ejection by oxytocin. So both are examples of neuroendocrine reflex. Okay, next, what is the substance X? Actually, these are the PYQs. Okay, now see here, there is a G protein coupled receptor. You know, in the cell membrane, there is a G protein coupled receptor. When the ligand binds with the G protein coupled receptor, something is happening. See, within the cell, this is the G protein, alpha subunit, beta subunit, gamma subunit. Now, when a ligand is binding here, what happens is the GTP from here, the GTP will move away actually. Okay, along with the alpha subunit. This alpha subunit along with the GTP. Initially there will be GTP, but when the ligand comes and binds there, GTP will go and bind. This alpha subunit is moving away. That's all biochemistry. Now, what is this doing? It is activating an enzyme called as adenylyl cyclase in the cell membrane. So, adenylyl cyclase in the cell membrane is getting activated. So, what this adenylyl cyclase will do? It converts ATP into. Now, tell me, adenylyl cyclase converts ATP into CAMP. That's a cyclic AMP. That's a secondary messenger. Now, cyclic AMP, what it will do? It activates a protein kinase, and protein kinase do a lot of things. So, the point which I want you to know is, so once you have the activation of adenylyl cyclase, what it does? It increases which levels? It increases intracellular levels of CAMP, cyclic AMP. When guanylyl cyclase, when this enzyme, when guanylyl cyclase in the cell membrane is, when it is activated, it increases the intracellular levels of cGMP. Okay. When one more enzyme in the cell membrane, which is called as phospholipase C, when it is activated, it increases intracellular levels of IP3. So now you might be thinking, why I am talking about all these things? What are these? The CAMP, CGMP and IP3. These are all secondary messengers. Okay, these are all secondary messengers. So cyclic AMP levels are increased by adenylyl cyclase, cyclic GMP levels are increased by guanylyl cyclase, and IP3 levels are increased by phospholipase C. Okay, so these are the points which I want you to know. See, here answer is cyclic AMP. Next, right now I have explained you CAMP, CGMP and IP3. What are they? They are secondary messengers. Okay, they are secondary messengers. So which hormones? Okay, which hormones use a CAMP as a secondary messenger? Okay, which hormones use a CAMP as its secondary messenger? Okay, so some students might be thinking, what is this secondary messenger systems? Hormones cannot directly enter into the cells. Okay, for example, let's say, now imagine this is one hormone. It is having a receptor here. Okay, there is one hormone. Say, let's say X. Now, when this X hormone, when it's coming and acting on its receptor, okay, it increases intracellular levels of secondary messengers like CAMP. Or it may increase, for example, let's say different hormone. When this different hormone comes and binds with the receptor, it increases the intracellular levels of cGMP. When a totally different hormone, for example, some different hormone comes and binds with this receptor, it increases intracellular levels of IP3. So they do their function. CAMP do certain functions, CGMP do certain functions, IP3 do certain functions. Okay. So what CAMP will? Which hormones uses CAMP as its secondary messenger? Which hormones uses cGMP as its secondary messengers? That I will discuss now. Here I have already given a list. Look, CAMP, okay, is a secondary messenger used by which hormones? Anterior pituitary hormones like FSH, LH, ACTH, TSH. Okay, FSH, LH, ACTH, TSH. These hormones, they uses CAMP, cyclic AMP. Okay, especially which I want you to know for your exam. Even hypothalamic hormones like corticotropin releasing hormone, growth hormone releasing hormone uses the same thing. But for your exam, I want you to know FSH, LH, ACTH, thyroid stimulating hormone, they all increases the intracellular levels of CAMP. Okay, and parathyroid hormone, other hormones like a glucagon, when antidiuretic hormone acts on the B2 receptors, histamine acting on H2 receptors, okay, beta HCG, melanocyte stimulating hormone, they all increases the intracellular levels of CAMP. So again, as a recap, let's write which hormones? FSH, LH, ACTH, okay, and TSH, thyroid stimulating hormone. These anterior pituitary hormones increases the intracellular levels of CAMP. Next, parathyroid hormone, glucagon, okay, antidiuretic hormone acting on its V2 receptors, histamine acting on H2 receptor, okay. Next, glucagon, antidiuretic hormone, histamine, and just now I have explained you the hormones like beta HCG. Okay, beta HCG increases the intracellular levels of CAMP, and melanocyte stimulating hormone. So they all increase the intracellular levels of CAMP. If you can remember, also you can remember growth hormone releasing hormone and corticotropic releasing hormone. Growth hormone releasing hormone, corticotropic releasing hormone. They also increase the intracellular levels of CAMP. Okay. Next, which hormone increases the level of intracellular levels of CGMP? Okay, CGMP. So CGMP is increased by atrial natriuretic peptide and brain natriuretic peptide. Okay, atrial natriuretic peptide produced from the atria, brain natriuretic peptide produced from the ventricles, and nitric oxide, important, very important. Nitric oxide, when it acts on the cells, okay, nitric oxide when it acts on the cells, it increases the intracellular levels of CGMP. Biochemistry important MCQ. Nitric oxide is a derivative of which amino acid? Arginine. Okay. So arginine will be converted into nitric oxide. Arginine will be converted into nitric oxide with the help of enzyme nitric oxide synthase. Now this nitric oxide and atrial natriuretic peptide for your exam, they uses intracellular levels of CGMP. They increases the intracellular levels of CGMP. Okay. So here also I have given, look carefully, CGMP levels, ANP, BNP and nitric oxide. Okay. And inositol triphosphate, IP3. So who increases the inositol triphosphate levels, IP3 levels? Remember, listen carefully. Wherever you see contractions and constrictions, for example like vasoconstriction. Okay, vasoconstriction, what do you require? Smooth muscle contraction, or contractions. Wherever you see this word contractions and constrictions, or any hormones, I should say any hormones which causes the contractions and constrictions, they all uses IP3 as the secondary messenger. For example, let's look at here. Oxytocin, what it does? Oxytocin causes uterine contractions. Okay, oxytocin causes uterine contractions. So oxytocin uses which secondary messenger? Oxytocin, when it is acting on the smooth muscle cells, oxytocin increases the levels of IP3. Okay, and antidiuretic hormone, don't confuse, antidiuretic hormone when it is acting on the V2 receptors, it is different. ADH, when it acts on V2 receptors, it increases the intracellular levels of CAMP, but antidiuretic hormone when it acts on the V1 receptors, they are present on the blood vessels. Okay, they are actually present on blood vessels. V1 receptors are present on the blood vessels. So antidiuretic hormone when it is acting on the V1 receptor, it causes vasoconstriction. Okay. Next, histamine, when it acts on H1 receptor, it causes bronchoconstrictions. Again the words contractions and constrictions. Wherever you see the word contractions and constrictions, they all uses IP3 as the secondary messenger. Angiotensin 2, vasoconstriction. Gastrin, GIT contractions. Okay. So remember, oxytocin, antidiuretic hormone, histamine, gastrin, angiotensin 2, they all uses IP3 as their secondary messenger. So what are the three secondary messengers that I have discussed with you? Cyclic AMP, cyclic GMP, IP3. And also I want you to know IP3, what it does? IP3 increases the intracellular levels of calcium. IP3 increases the intracellular levels of calcium, and that calcium is responsible for the contraction of the smooth muscles. Okay, smooth muscle contractant. Okay, so you might be thinking why I am discussing this. See, look here, IP3. Okay, IP3, inositol triphosphate. What it is doing? It increases the intracellular levels of calcium. So with this calcium, what it will do? Uterus will contract. Oxytocin causes a uterine contraction. With that calcium, there will be contraction of the vascular smooth muscle. The vascular smooth muscle will be contracted. That will cause vasoconstriction. Histamine, with that calcium, histamine, what it does? Histamine, it increases the intracellular levels of IP3. IP3, what it does? IP3 further increases the intracellular levels of calcium. Calcium is helping in the bronchoconstriction. Okay, bronchoconstriction. So like that. Okay, so remember, IP3 increases calcium. IP3 increases calcium. MCQ. It's a question. Okay, so which secondary messenger increases the levels of calcium inside the cell? IP3 increases the calcium. Okay, now let's look at here one more question. In a patient with a suspected endocrine dysfunction, okay, let's say there is a patient with a suspected endocrine dysfunction, which hormone primarily acts to the following pathway shown here. This is all nonsense, a very simple thing. See, here just by looking at this image I can say, so there are certain things like Janus kinases which are getting phosphorylated, Janus kinases, and these STATs are there, signal transduction and activator of transcription STAT are there. So it is the JAK-STAT pathway, it's a classical pathway, okay, which was given in the exam. So this is the JAK-STAT pathway. So who uses the JAK-STAT pathway? So JAK-STAT pathway is used by hormones like leptin. Okay, leptin. Okay, leptin. JAK-STAT pathway uses JAK-STAT pathway. Here itself, which I want you to know is leptin is produced from adipocytes. Okay, leptin what it does? It's produced from adipocytes. Leptin, what it does with the hunger? It decreases the hunger. Leptin decreases the hunger. Okay, leptin decreases the hunger. So as it is decreasing the hunger, it is called as anorexigenic hormone. Okay, anorexia, you know it, right? No hunger. So anorexigenic hormone. And not only that, this leptin, okay, they have a permissive role during puberty. Okay, permissive role during puberty. Okay, these are some important points which I want you to know. Leptin uses JAK-STAT pathway. Leptin is produced by the adipocytes. Leptin decreases the hunger. That's why it's called as anorexigenic hormone. It have a permissive role during puberty. Not only this leptin, even others uses JAK-STAT pathway. Who else uses the JAK-STAT pathway? MCQs. Prolactin and growth hormone. They uses which pathway in the cell? I'm not talking about the receptor. They uses which pathway? They use JAK-STAT pathway. So JAK-STAT pathway is used by leptin, prolactin, growth hormone, and not only them, certain growth factors, for example like erythropoietin, granulocyte colony stimulating factor, thrombopoietin, they also uses JAK-STAT pathway, okay, and interferon gamma, interleukin 2, interleukin 6. But for your exam, I just don't want you to know all these points. At least leptin uses JAK-STAT pathway, prolactin uses JAK-STAT pathway, growth hormone uses JAK-STAT pathway. Okay. Now I am talking about the tyrosine kinase receptors. Okay, tyrosine kinase receptor. I am talking about the receptor now. Okay, the receptor which is present on the cell surface. For example, let's say here is a receptor. Here is a receptor on the cell surface. Intracellularly, it is associated with an enzyme, tyrosine kinase. Intracellularly, it is attached with a tyrosine kinase enzyme. So, which hormones will come and bind with this tyrosine kinase receptors? Okay, insulin and growth factors. Okay, see, now I am not talking about the growth hormone now. Growth hormone, prolactin, leptin. Growth hormone, prolactin, leptin. They use JAK-STAT pathway. That's completed. The topic completed. Done. Now I am talking about insulin. It uses tyrosine kinase receptor and growth factors like platelet growth factor, vascular endothelial growth factor, insulin-like growth factor. These growth factors, wherever you see the word growth factors, they uses tyrosine kinase receptor. Okay, tyrosine kinase receptor. These are all the PPQs. Okay, so done. Again, tyrosine kinase receptors are used by insulin, at least one thing. JAK-STAT pathway is used by growth hormone, prolactin, leptin. Okay, leptin, important points, anorexigenic hormone produced from the adipocytes, decreases the hunger. It have a permissive role during puberty. It takes you into the puberty. Okay, so cyclic AMP, cyclic GMP and IP3, these are the three secondary messengers. And which hormones uses CAMP? You know it. CAMP, you know it. IP3, you know it. Okay, so next MCQ. Now let's say there is a beta 2 receptor. Beta 2 receptor means adrenergic receptor, sympathetic receptor. So for example, let's say here there is a beta 2 receptor. Who will act on the beta 2 receptor? Epinephrine is going to act. When epinephrine is acting on this beta 2 receptors, the stimulation of this beta 2 receptors, look, when you stimulate the beta 2 receptor, what happens? Beta 2 stimulation is going to activate something called as adrenaline cyclase. I have told you. Once the adrenaline cyclase is activated, ATP will be converted into CAMP. So intracellular CAMP levels increases. So the point which I want you to add is CAMP is a secondary messenger which will also be used by these sympathetic hormones. So epinephrine, norepinephrine. So add here not only this glucagon, antidiuretic hormone, histamine, also add here epinephrine. Okay, epinephrine, norepinephrine. So they also increases the intracellular levels of CAMP. Okay. So now what's the answer here? So beta 2 receptor activation leading to some result, hyperglycemia, hypoglycemia, is mediated by which of the following secondary messenger? CAMP. By which enzyme? Adenylyl cyclase. Adenylyl cyclase. So remember. Okay, it will come in pharmacology also. Beta 2 receptor stimulation activates adenylyl cyclase. Adenylyl cyclase converts ATP into CAMP. CAMP activates protein kinase A, and a lot of things will happen. Which of the following is having a tyrosine kinase receptor? I have told you. Tyrosine kinase receptor is there for two things: insulin and growth factor. Okay, insulin and growth factors. Next, here the point which I want you to know is regarding the thyroid hormones. Thyroid hormones, where are their receptors present? T3 active form, right? Thyroid hormones have, right? Thyroid hormones. They have intranuclear receptor. This is the MCQ. Thyroid hormones, a new receptor. Thyroid hormone receptor is present within the nucleus. So they have intranuclear receptor. Thyroid hormones have intranuclear receptor. So even these hormones, the intranuclear receptors and sex hormones, okay, intranuclear receptors and sex hormones, even they have intranuclear receptors. Now let's discuss a few more important questions. Stimulus for the release of vasopressin. What is the stimulus for the release of vasopressin? Can you tell me what is the other name for vasopressin? Vasopressin, other name is antidiuretic hormone. Important points where it is produced. It is produced in hypothalamus. Okay, it's produced in hypothalamus, not the posterior pituitary. It is stored in posterior pituitary. Okay, it's stored in the posterior pituitary. But the recent question which was asked in the exam says, it is produced by which nucleus of the hypothalamus? Yes, hypothalamus produces antidiuretic hormone. Which nucleus of the hypothalamus? There is a nucleus called as a supraoptic nucleus. The supraoptic nucleus, important MCQ, it produces antidiuretic hormone, and this antidiuretic hormone, it is stored in posterior pituitary in the vesicles. Okay, so antidiuretic hormone is produced and stored in these vesicles. These vesicles are called as Herring bodies. Herring bodies. Okay, so supraoptic nucleus produces antidiuretic hormone, and one more nucleus called as a paraventricular nucleus, it produces oxytocin. Okay, paraventricular nucleus produces oxytocin. Now, what is the stimulus for the release of antidiuretic hormone? What is the stimulus when antidiuretic hormone is going to be released? Now, in the name itself, it is there, see, antidiuresis. Antidiuresis means anti-urination. It decreases the volume of urine that is getting produced. In which condition you want to produce less urine? When you are getting dehydrated. For example, let's say you went to a desert. Okay, went to a desert. Now, in the desert, you are getting sweat. Okay, you are getting sweating. Now, when you are getting sweating, what happened to your blood volume? Blood volume decreases. Means you are losing the pure fluids out of your body. You are losing the fluid. Sweat, hypotonic fluid. Sweat is a hypotonic fluid. Remember, sweat is a hypotonic fluid. Okay, which means you are losing the diluted fluids out of your body. So what happens to your plasma? The plasma is getting concentrated. Okay, your plasma is getting concentrated because you are losing the fluids. The plasma is getting contracted and concentrated. What happened to the plasma? It becomes hyperosmolar or hypertonic. Okay, there will be hypertonicity. Now tell me, this is the time you are supposed to lose the fluids? No, already you are losing the fluids in the form of sweat. So this is not the time to produce more urine. Okay, this is not the time to produce more urine. So that's why this hyperosmolarity will be detected by osmoreceptors. Osmoreceptors, where are they present? These osmoreceptors, they are present in subfornical organ, in brain, subfornical organ, and organum vasculosum. Okay, so subfornical organ and organum vasculosum, what are they? They are osmoreceptors. They are osmoreceptors. Now they detect the change in the hyperosmolarity. They detect the change in the osmolarity of the plasma. The plasma is getting hyperosmolar, so these osmoreceptors are activated. Now activation of these osmoreceptors is the one which leads to the release of antidiuretic hormone. So what is the stimulus for the release of antidiuretic hormone? It is hypertonic plasma. Antidiuretic hormone also called as vasopressin. Antidiuretic hormone, some more important MCQs, let me write here. Where is this antidiuretic hormone going to act? What is its function? Antidiuretic hormone, it acts on the last part of the nephron. See, this is the last part of the nephron, which is called as a collecting duct. Okay, this is the collecting duct. So these cells are called as the principal cells. Now on these cells there is a V2 receptor present. Now antidiuretic hormone acts on this V2 receptor. Okay, antidiuretic hormone acts on V2 receptors. So now for the first time these principal cells, they will incorporate these channels, water channels. So with the help of these water channels, water will be reabsorbed into the cell. So in the presence of antidiuretic hormone, see only in the presence of antidiuretic hormone, the V2 receptors are stimulated. Now the collecting duct, okay, now the collecting duct, it becomes permeable to water. So what is the name of these water channels? The name of the water channel is called as aquaporin 2. So with the help of aquaporin 2 channels, the collecting duct is reabsorbing the water. This is called as facultative water reabsorption. Okay, this is called as a facultative water reabsorption. So tell me, antidiuretic hormone, under the influence of the antidiuretic hormone, the water is getting reabsorbed in the collecting ducts with the help of aquaporin 2 channels. Okay, this is called as facultative water reabsorption. Okay, now sometimes they can trick you. Under the influence of antidiuretic hormone, maximum water is reabsorbed in. Maximum water reabsorbed. So where maximum water is reabsorbed? See, it doesn't matter whether the antidiuretic hormone is there or not. Doesn't matter. Always maximum water is reabsorbed in the PCT. Okay, how much water will be reabsorbed in the PCT? 70% water will be reabsorbed in the PCT. Always. That is called as obligatory water reabsorption. Obligatory water reabsorption. So tell me, obligatory water reabsorption occurs in PCT. Facultative water reabsorption occurs in collecting ducts. What is the receptor for the antidiuretic hormone? The receptor for the antidiuretic hormone is V2 receptor. V2 receptor. Okay, done. Next, the cells shown in this image secretes which of the following? For example, let's say here is a cell, here is a cell. Okay, the cells shown in this image secrete which of the following hormone? First of all, this is the histology of which tissue? Thyroid gland. Okay, here is the thyroid gland. So you can very clearly see these things which I am highlighting here. These are all colloids. Okay, this is a colloid place where T3 and T4 are stored. Okay, the place where T3 and T4 are stored. These are the colloids. Now, if you look at the thyroid gland, see here I am showing you thyroid gland. Now, in this thyroid gland, there are follicular cells present. For example, let me show you one follicle. In the center there is colloid. These cells which I am drawing here, okay, these are all cells. What are these cells? These are all follicular cells. Follicular cells. These follicular cells are the ones which produce the T4 and T3 thyroid hormones. Now, surrounding these follicular cells, there are also parafollicular cells present. These parafollicular cells, these parafollicular cells, they produce calcitonin. What is the function of this calcitonin? Calcitonin decreases the calcium levels in the body. Okay, if calcitonin decreases the calcium levels in the body, who increases the calcium levels? Parathyroid hormone increases the calcium levels in the body. Here itself I want you to know, say calcitonin decreases the calcium, parathyroid hormone increases the calcium, so these are antagonistic hormones. Okay, they are antagonist hormones, physiological antagonist. One increases the calcium, one decreases the calcium. Now, parathyroid hormone, look, parathyroid hormone, it increases the calcium, but what it does to the phosphates? It decreases the phosphate levels in the body. Okay, parathyroid hormone decreases the phosphate levels in the body. That's why I used to remember it. So it's a phosphate trashing hormone, PTH. Phosphate will be trashed out of the body. So it decreases the blood levels of phosphate. So phosphate trashing hormone. Okay, so calcitonin and parathyroid hormone, they are physiological antagonists. Okay, now integration, as a part of integration, here itself let me tell you, see if there are cancers to the thyroid gland. Okay, there are different types of cancers, follicular cell cancer, okay, papillary cancer of the thyroid gland, medullary carcinoma of the thyroid gland, anaplastic carcinoma of the thyroid gland. There are different types of cancers. Now if these parafollicular cells, look, if these parafollicular cells, if they get cancer, okay, they got malignancy, that is called as, okay, cancer of the parafollicular cells is called as medullary carcinoma. Medullary carcinoma of thyroid gland. Okay, medullary carcinoma of thyroid gland. Now tell me what happens in this medullary carcinoma of thyroid gland. It's excessive production of calcitonin. It's a peptide hormone. There will be excessive production of this calcitonin. So more and more calcitonin will be present in the tissue. Okay. So in between the follicles, in between the follicular cells, there is more and more production of the calcitonin. Okay. So what this calcitonin is going to do? The calcitonin is going to decrease the blood calcium levels. Okay. So if a person is going to get the medullary carcinoma of the thyroid gland, his calcium levels are going to go down. So there will be hypocalcemia. Now here the points which I want you to know is, if a patient is having hypocalcemia, the calcium levels are going down, he is going to show two physical signs. Okay, two physical signs. If you do physical examination, he is going to do two physical signs. One is called as Trousier sign. Trousier sign. Okay, Trousier sign. This is nothing but the carpopedal spasm. Okay, you know, the image also going to look something like this. Okay, carpopedal spasm. If you put a BP cuff and if you increase the pressure, immediately there will be carpopedal spasm. This is called as Trousier sign. And there will also be Chevostic sign. Okay, Chevostic sign. If you tap on the parotid gland, that will cause the unilateral, there will be contractions. You can see the unilateral contractions of the face, that is called as the Chevostic sign and Trousier sign. So hypocalcemia is going to cause two signs, that is Trousier sign and Chevostic sign. And also if a patient is going to have less amount of calcium, is going to have tetany. Okay, he is going to have tetany, abnormal muscle contractions. So abnormal muscles, the muscles are going to be contracting. Okay, the muscles are going to be contracting abnormally. Okay, so that's going to make a person go into such kind of posture. Imagine here is a bed. Okay, here is a bed. Now because of the spasms, he is going to have such kind of, like we have seen these images many times, a person is going to just go back like this as if he is possessed. Okay, so this position is called as opisthotonous posture. Okay, opisthotonous posture or opisthotonous position. So all these points are regarding the calcium, because calcium is very important for your exam. Okay, so hypocalcemia means Trousier sign, Chevostic sign, tetany can be seen, opisthotonous posture can be seen. What are the two important antagonistic hormones? Calcitonin and parathyroid hormone. So what is medullary carcinoma of thyroid gland? Medullary carcinoma of thyroid gland is a cancer of parafollicular cells. This medullary carcinoma of thyroid gland is going to be associated with which syndrome? Men syndrome. Multiple endocrine neoplasia type 2 in men too, that is both 2A and 2B. The patients will develop medullary carcinoma of thyroid gland. MCQ. Now, thyroxine, that is a T4, thyroxine has maximum affinity for which of the following? Okay, thyroxine have maximum affinity for which of the following? See, for this I want you to know the differences between T3 and T4. See, T3 and T4. Okay, T3 is an active hormone. Okay, T3 is active, T4 is less active. This is more active. Okay, T3 is more active form. See, T3 half-life is going to be 1 day. Okay, 24 hours. Is going to stay only for very less time, because it's not going to be bound with the plasma proteins. Okay, it's going to not tightly bound with the plasma protein, so it is easily metabolized. But T4, which is the real store of the thyroid hormone, T4 is the real store of thyroid hormone, it stays for almost 7 days. Okay, 6 to 7 days in your blood, because T4 mainly binds with thyroid binding globulins. T4 mainly binds with the thyroid binding globulins. So it stays in the blood for a longer time. Once if it is bound with the plasma protein, it is not going to be destroyed. So what is that? Thyroid binding globulin. T3 binds with albumin. Okay, thyroid binding pre-albumin, something like that. But anyway, in your exams, what they will ask you is the T4 mainly bound with thyroid binding globulin. Okay, who is the active form? T3, not the T4. Okay, so let me add a few more important points about the thyroid gland here. Let me write important points. Thyroid hormones. See, these thyroid hormones are anabolic or catabolic. They are predominantly catabolic. Okay, they are catabolic hormones. So what they do to the blood glucose levels? They increases the blood glucose levels. What do they do to the proteins? Proteolysis. Okay, they cause the proteolysis. And what they do to the lipids? Lipolysis. Okay, they cause the lipolysis. What they do to the BMR, basal metabolic rate? The basal metabolic rate, important MCQ, the basal metabolic rate increases. The thyroid hormones increase the basal metabolic rate. How? They will ask you. How they will increase the basal metabolic rate? Your answer should be they increases the number of sodium potassium ATPases on the cell surface. Okay, they increase the number of sodium potassium ATPases. So by increasing the number of sodium potassium ATPases means more ATP will be broken down. More ATPs are getting broken down means automatically your basal metabolic rate, the number of calories that will be used by the body to keep the body in homeostasis. That's what is the basal metabolic rate. So if thyroid hormones are more in your body means your basal metabolic rate increases. They also increase your body temperature. Okay, that's why they are called as thermogenic hormones. Okay, they are thermogenic hormones. Okay, next, what else they do? Thyroid hormones during childhood, they helps in development of brain. Now you can say nervous system. They also help in development of bones and skeleton. Okay, bones and skeleton. So that's why if a patient is having deficient of thyroid hormones, congenital hypothyroidism. Okay, congenital hypothyroidism is going to cause a condition called as cretinism. Okay, it's going to cause a condition called as cretinism. So in this cretin babies, tell me, do you think the brain will be developed? No, no brain development, no skeletal development. So these babies are going to be dwarf. Okay, these babies without thyroid hormones they are going to be dwarf and they are going to be mentally retarded. Okay, so these babies with the cretinism they are going to have mental retardation and dwarfism because thyroid hormones are not there. Without thyroid hormones, no brain development, no bones development. So congenital hypothyroidism can lead to cretinism. Okay. Next, here itself I want to add a few more points. See, thyroid hormones. Okay, how they are produced? How they are produced? If you understand how they are produced, I will explain you one of the important MCQ. Okay, look. See, here is hypothalamus. Let's say here is the hypothalamus. Down to it, here is the anterior pituitary, and here is the thyroid gland. Okay, let's say here is the thyroid gland. Normally, hypothalamic nucleus, what they produce is TRH, thyrotropin releasing hormone. Okay, thyrotropin releasing hormone. Now, this thyrotropin releasing hormone, it comes and acts on thyrotropes. It comes and acts on thyrotropes. Now, these thyrotropes, look carefully. Now, these thyrotropes, they produce TSH. Now, this TSH is going to come and act on the follicular cells. They will come and act on the follicular cells of the thyroid gland, follicular cells of the thyroid gland. So, these follicular cells produce T3 and T4. Okay. So, this T4, whatever the T4 that is getting produced, T4 will give negative feedback. Okay. Negative feedback is given by T4 MCQ. Okay. T4 gives negative feedback. Now, look, for example, imagine in this patient, thyroid gland is damaged. Okay, thyroid gland is damaged. So, can you tell me in which condition thyroid gland will be damaged? For example, let's say Hashimoto's thyroiditis. So, in Hashimoto's thyroiditis, thyroid gland is damaged. Now, when the thyroid gland itself is damaged, means something there is problem in the thyroid gland. Hashimoto's thyroiditis, autoimmune destruction of the thyroid gland. Okay. So, now what happened to the T3, T4 levels? The T3, T4 levels decreases. No T3, T4. Okay. So, now what happened to the TRH levels? Tell me. The TRH levels are going to be more. Okay. The TRH levels are going to be more. Now, more TRH. Okay. Now, this TRH, increase in the TRH, thyrotropin releasing hormone. Now, this increase in the TRH, what it will do is, it will also stimulate, the TRH will also stimulate the lactotropes. Okay, in high quantities, the TRH is also stimulating what? Lactotropes. What does this lactotropes release? Prolactin. Okay, prolactin. So, now unnecessarily prolactin is getting produced, that is going to cause galactorrhea. So, One important MCQ which I want you to know is, now this patient is having hypothyroidism or hyperthyroidism. You know it, hypothyroidism, no T3, T4. So this hypothyroidism is an example of primary hypothyroidism, primary hypothyroidism. Okay, so tell me, in a patient who is having primary hypothyroidism like Hashimoto's thyroiditis, they also have galactorrhea. Okay, they also have galactorrhea. Okay, so increase in the levels of TRH, thyrotropin releasing hormone, also stimulate the lactotropes to release prolactin, and they have galactorrhea. Important MCQ. Okay, so primary hypothyroidism can lead to galactorrhea, not the secondary, primary hypothyroidism. Okay, this is the point. Next, what else you should know regarding the thyroid hormones? Look, important points about thyroid hormone synthesis. There is a enzyme which is called as thyroid peroxidase. Okay, there is an enzyme called as thyroid peroxidase. This enzyme is very much important because to produce T3-T4, you require this enzyme, TPO. So what it will do is, it helps in three reactions: oxidation, organification, and coupling reaction. So what I am trying to put into your mind is, in the process of production of T3-T4, you need to have three steps: oxidation, organification, and coupling reaction. These three reactions are catalyzed by thyroid peroxidase. Okay, so this thyroid peroxidase is a very important enzyme. Okay, it's a very important enzyme. It is catalyzing oxidation, organification, and coupling reaction. So ultimately, who is produced? T3 and T4 are produced. Okay, point is, you can inhibit this thyroid peroxidase. Okay, you can inhibit the thyroid peroxidase. So how to inhibit this thyroid peroxidase? Inhibit. Who inhibits this thyroid peroxidase? Drugs like propylthiouracil, okay, propylthiouracil, carbimazole, methimazole. So these drugs, carbimazole, methimazole, propylthiouracil, they inhibit the thyroid peroxidase. So what happened to T3-T4 levels? Decreases. So these drugs are anti-thyroid drugs. Okay, these drugs are anti-thyroid drugs. Especially propylthiouracil is MCQ. Propylthiouracil, it is a drug of choice for hyperthyroidism during first trimester of the pregnancy. It is drug of choice for hyperthyroidism during first trimester of the pregnancy. Okay, during first trimester of the pregnancy, propylthiouracil. This carbimazole, methimazole, you are not supposed to use them because they are going to be associated with the teratogenicities. Okay. Next, what else I should teach you here is, normally who is going to be produced in more quantity? T4 is going to be produced in more quantity. So the T4 will be converted into T3 active form. Okay, where in the tissues, wherever it is required. Okay, wherever it is required. So in the place wherever it is required, T4 will be converted into T3. T3 is active form. Question is, who is going to convert this T4 into T3? There is an enzyme called as 5'-deiodinase. Okay, so with the help of this enzyme called as a deiodinase, T4 will be converted into T3. So this reaction is called as peripheral conversion. Okay, this is called as peripheral conversion. So this peripheral conversion can also be inhibited in certain conditions. Okay, in certain conditions you have to inhibit this peripheral conversion. For example, if a patient is having thyroid, you will study in your pathology and medicine this emergency condition called as thyroid storm. Okay, there is a condition called as thyroid storm. In this thyroid storm, what happened? Suddenly there is increase in the levels of thyroid hormones in the body. Suddenly there is increase in the levels of thyroid hormones in the body. Suddenly it have increased. They have increased. Why they have increased? There is a reason. Okay, I am not going to that. Suddenly if T3, T4 levels increase in the body, that is called as a thyroid storm. So what you have to do immediately, you have to inhibit this conversion. You have to inhibit the conversion of T4 into T3. So you have to use peripheral conversion inhibitors. Again, what are they? Propyl thiouracil, PTU, and propranolol. Okay, propranolol and propyl thiouracil, they are peripheral conversion inhibitors. They can be used in the treatment of thyroid storm. Okay, now what else you should know before going to the exam regarding the thyroid hormones? There is something called as Wolff-Chaikoff effect. Okay, Wolff-Chaikoff effect. So what is this Wolff-Chaikoff effect? For example, I am asking you suddenly you have taken excessive amount of iodine. You know iodine is helping in the thyroid hormone production. Iodine helps in the thyroid hormone production. Iodine will be used in the production of T3, T4. Suddenly you have taken more iodine into the body. So do you think that iodine will be helping in the production of excessive T3 and that excessive T3 is going to cause hyperthyroidism? No, answer is no, it's not going to happen like that. Okay, it's not going to happen like that. So even though by mistake if you take excessive amount of iodine, there won't be any hyperthyroidism. Okay, so why? Because let me write here, if you take excessive iodine, okay, if you take excessive iodine, that excessive iodine is going to inhibit thyroid peroxidase. The thyroid peroxidase will be inhibited. Oxidation, organification, especially organification process is going to be inhibited. So intake of excessive iodine intakes inhibit thyroid peroxidase. So what actually happened to the T3, T4 production? Actually goes down. Oxidation, no organification, no coupling reaction. So T3, T4 hormone production goes down. This is called as a Wolff-Chaikoff effect. This is a beneficial effect. It is used before the thyroid surgeries. I am not going into any details. But what is Wolff-Chaikoff effect? If you take excessive amount of iodine, that inhibits the thyroid peroxidase, that further decreases the T3, T4 production. Okay, just simply like, for example, you are working for money. Okay, for example, you are working for money. All of us are working for the money. Okay, if suddenly I gave you $1 billion, okay, you got a check that you got $1 billion. Are you going to work from tomorrow? No, definitely you are not going to work from tomorrow, right? So normally iodine helps in the production of T3, T4. But if you give lots and lots of iodine to the thyroid gland at a time, okay, if you give lots and lots of iodine to the thyroid gland at a time, again and again, actually we do this for 10 days. If you're giving iodine again and again, the thyroid peroxidase activity will be inhibited. Okay, so that is called as Wolff-Chaikoff effect. Next effect, Jod-Basedow effect. Jod-Basedow effect. So what is this Jod-Basedow effect? Jod-Basedow effect is taking, for example, now Wolff-Chaikoff effect is failed. Now the Wolff-Chaikoff effect in this particular fellow, it is failed. So now the person have taken iodine. So why he is taking iodine, sir? You can ask me why he is taking iodine. Maybe he is using radioactive iodine for thyroid scan. Now we have injected radioactive iodine into his body. We have given radioactive iodine into his body for the thyroid scan purpose. So radioactive iodine we have given. So this radioactive iodine is also a form of iodine, right? So where this radioactive iodine will go? It will go into the thyroid gland. Okay, it will go into the thyroid gland. So by using this iodine, his thyroid gland is making T3 and T4. Means after this radioactive iodine uptake study, his thyroid gland is producing more T3, T4. He have gone into hyperthyroidism. Okay, after doing this study, he have gone into hyperthyroidism. So this is called as Jod-Basedow effect. So Jod-Basedow effect is iodine inducing the production of T3, T4. Wolff-Chaikoff effect is iodine decreasing the T3, T4. Okay, if Jod-Basedow effect is failed, if it is failed, it causes Jod-Basedow effect. Okay, so these are the important points about the thyroid hormones. Important is thyroid hormones have intranuclear receptors. T3 is active form. Okay, thyroid peroxidase causes oxidation, organification, coupling reaction. Peripheral conversion inhibitors, propyl thiouracil. Peripheral conversion means conversion of T4 into T3. Peripheral conversion is inhibited during thyroid storm. Okay, so these are all the important points which I want you to know. In primary hypothyroidism, there will be galactorrhea can be seen. These are important points about thyroid hormones. Okay, now let's see some other questions. Which of the following conditions would have a very high levels of ACTH and cortisol? Very high levels of ACTH and cortisol. See here, both ACTH is there and cortisol is also there. Which of the following conditions? The answer is, okay, the answer is, let me tell you first, before telling you the answer, let me tell you what is something normal. Okay, what is something normal? Look here carefully. Here is the hypothalamus, here is the pituitary gland, here is the kidneys. Okay, let me draw the adrenal gland, no need of kidneys. Here is the adrenal gland with two regions, adrenal cortex as well as adrenal medulla. Now, this hypothalamic nucleus, it is releasing CRH, corticotropic releasing hormone, corticotropin releasing hormone. This corticotropin releasing hormone is coming and acting on the anterior pituitary. It's acting on the corticotropes. So now these corticotropes are releasing ACTH, adrenocorticotropic hormone. Now this adrenocorticotropic hormone is going to act on the adrenal cortex. Now the adrenal cortex is going to produce cortisol. Now this cortisol, it gives negative feedback. Okay, it gives negative feedback. Okay. Now what if the patient is having, okay, what if the patient is having a tumor here? In the anterior pituitary, there is a tumor of the corticotropes, there is a tumor. Now this tumor, what it will do? Now this tumor is going to produce more ACTH. Now whenever there is more ACTH in the body, also cortisol levels will be increased, more and more cortisol. Now this cortisol can't give the negative feedback because here the problem, here there is a tumor. This tumor is not going to be responding. This tumor is not going to be responsive to the negative feedback. So this patient is going to have high levels of ACTH as well as high levels of cortisol. So a tumor in the pituitary gland is called as Cushing disease. Okay, in Cushing disease, the patient is going to have excessive high levels of ACTH as well as excessively high levels of cortisol. Okay, so during early morning, ACTH levels will be more and cortisol levels will be more, but not too much, not very high, not very high. Okay, so now you know what is Cushing disease. Cushing disease is a condition where there is a tumor of pituitary gland with more ACTH as well as more cortisol. Now some important points regarding the Cushing disease. Say, what is the most common cause of Cushing disease, or I should say Cushing syndrome first of all. Okay, Cushing disease is the tumor of the pituitary gland. Now, what is the most common cause of Cushing syndrome? You know, Cushing syndrome means what? There is excessive cortisol, hypercortisolism. Okay, hypercortisolism is called as the Cushing syndrome. There is excessive amount of cortisol in the body, right? Now see, what is the most common cause? Iatrogenic. Okay, iatrogenic. Doctors are prescribing excessive amount of steroids. Okay, doctor prescribes steroids. Excessive amount of steroids. Okay, steroids are nothing but the glucocorticoids. They act like cortisol. Okay. So what is the most common cause of Cushing syndrome or hypercortisolism? It is iatrogenic. Okay, it's iatrogenic. Now, if a patient is having Cushing syndrome, what kind of features the patient is going to have? What kind of features? So, cortisol is a catabolic hormone. It's a number one catabolic hormone. Catabolic hormone. It's a number one catabolic hormone. Okay, it's also called as stress hormone. So what it does to the body? Okay, what it does to the body is, look, number one, it increases the blood glucose levels. Okay, it increases the blood glucose levels. Yes, growth hormone increases the blood glucose levels, thyroid hormone increases the blood glucose levels, even cortisol increases the blood glucose levels. So cortisol increases the blood glucose levels. As it's a catabolic hormone, what it does to the proteins? Proteolysis. What it does to the fats? Lipolysis. Okay. Next, what it does to the skin or the connective tissue? See, the skin and connective tissues, they are made up of the collagen, right? The collagen will be broken down. The collagen is getting broken down. So there is breakdown of collagen in the skin and blood vessels. Because of the breakdown of the collagen in the skins, what happened? Tell me. The skin is going to become loose and loose. Okay, the more collagen means tight skin. Now in these patients, the skin is going to be very thin and it's going to be more stretchable because the collagen is lost. The elastic recoil property of the skin is going to be lost. So because of the collagen breakdown, is going to have abdominal striae. Okay, he's going to have abdominal striae. Not only this, say, because he is having high levels of glucose. Okay, he is having high levels of glucose, right? Now tell me, as you are having high levels of glucose, what happened to the insulin levels? Insulin levels are going to be more. They are going to have high levels of insulin. Because of this high levels of insulin, these patients are going to have adipocyte hypertrophy. Okay, they are going to have adipocyte hypertrophy. So these adipocytes are becoming bigger and bigger, and these adipocyte hypertrophy is going to happen especially in the central part of the body. In the central part of the body, leading to there will be obesity in the central part of the body. So there will be a big face and big chunky body. So there will be centripetal obesity. Okay, so the central part of the body is going to have obesity, and if you look at the extremities, because of this proteolysis, the muscles are getting broken down because of the cortisol. So what happened to the extremities? Thin extremities. Okay, they are going to have thin extremities. So the centripetal obesity and thin extremities is going to give a classical appearance called as lemon on stick. Lemon on stick appearance. Okay, lemon on stick appearance is going to be seen. Okay, so centripetal obesity, a few more important points. If a patient is having centripetal obesity, now if you look at his face, Cushing syndrome patient face, there will be moon face. Okay, there will be moon face because of this adipocyte hypertrophy, moon face. There will be buffalo hump. Okay, there will be buffalo hump, moon face, centripetal obesity, lemon on stick appearance. There will be myopathies. Okay, myopathy will be seen. Okay, thin extremities and joint pains, myopathy. Okay, so these are the points which I want you to know. Next, what else? See, this Cushing syndrome is a condition where there is excessive amount of cortisol. What kind of hormone is cortisol? Cortisol is a steroid. As you are having higher and higher amounts of steroids, what happened to your immune system? You know, steroids are immunosuppressants. Now in this Cushing syndrome, there will be immunosuppression. Okay, there will be immunosuppression. Because of this immunosuppression, the patient is going to have recurrent infections. Okay, these patients are going to have the recurrent infections. Next, what about the blood cells? See, cortisol, hypercortisolism. The cortisol increases the levels of neutrophils in the body. So neutrophils are going to increase, but all other WBCs, okay, is going to go down. Not only neutrophils, your RBCs and platelets, they're also going to increase. Okay, your neutrophilia, there will be neutrophilia, more RBCs, polycythemia and thrombocytosis will be seen. More number of neutrophils, more RBC as well as more platelets. Because of these three, the number of cells in the blood are going to increase, which leads to hyperviscosity of the blood. There will be hyperviscosity. So because of this hyperviscosity, there is a chance that these patients can develop deep venous thrombosis. Okay, they can develop deep venous thrombosis, or may be even more dangerous thing, that is pulmonary embolism. Okay, they may even develop pulmonary embolism, deep venous thrombosis or pulmonary embolism. Okay, so these are all the important points which are seen with the Cushing's syndromes. And not only this, for example, say, what about the GIT? A patient who is having Cushing syndrome, there will be more acid production. That more acid production is going to cause ulcers in the stomach. Cortisol is a stress hormone. During a stress state, do you want to have any reproductive hormones or any reproductive activity during the stress environment? No. So that's why cortisol, it inhibits GnRH. What happened to FSH levels? FSH levels goes down, LH levels goes down. So because of this, there will be amenorrhea. Okay, there will be amenorrhea in these patients. Now, and libido decrease, libido. Not only that, these patients who are having a Cushing syndrome, if you look at their skin, okay, if you look at the skin, the blood vessels are going to get damaged very easily, because blood vessels are made up of collagen. There will be collagen breakdown. So these blood vessels under his skin, the blood vessels under his skin are also very weak. So they are going to be easily damaged. Okay, they are going to be easily damaged. So that causes bleeding under the skin. Okay, bleeding under the skin. The blood vessels are getting easily damaged because the collagen is getting broken down. Not only that, these patients are also going to have hypertension. Cortisol increases the BP. Okay, one more important point is cortisol. Very important. They maintain the vascular tone. So cortisol increases the BP. So this patient is having hypertension. Okay, Cushing syndrome patient is having hypertension and weak blood vessels. So that's going to cause bleeding under his skin. So they might be having petechiae. Okay, they may have petechiae or purpura. Okay, petechiae, purpura can be seen. Okay, so these are all the important points. A patient with a petechiae, purpura, amenorrhea, deep venous thrombosis, pulmonary embolism. So don't think every time they are going to ask something like moon phase, buffalo hum. Of course, they are classical things. Okay, the moment you see the moon phase, straightforward you are going to answer Cushing syndrome. But they may trick you with this hyperviscosity. Okay, or they may say the patient is having a history of a deep venous thrombosis. The patient is having a high number of neutrophils. The patient is having petechiae, purpura under his skin. And also, if you look at their palms and soles, okay, there will be hyperpigmentation. Okay, there will be hyperpigmentation. This is also very important. So these are some important points which I want you to know for your exam regarding Cushing syndrome. Next, all are glucogenic hormones. All are glucogenic hormones except I have told you from the beginning. See, glucagon. You know from your biochemistry, glucagon is produced from which cells of the pancreas? Alpha cells of the pancreas. Okay, what glucagon will do? Glucagon increase the blood glucose levels. Glucagon causes the glycogenolysis, gluconeogenesis, it increases the blood glucose levels. Growth hormone also increases the blood glucose levels. Thyroid hormones, just now discussed, increase the blood glucose levels. Cortisol, stress hormone, increase the blood glucose levels. All of them increase the blood glucose levels. But insulin, what it do? It decrease the blood glucose levels. So one hormone who decrease the blood glucose levels, it is insulin. Okay. So under the influence of insulin, what happens? Tissues. Which tissues? Skeletal muscles as well as adipocytes. Okay, skeletal muscles as well as adipocytes. Under the influence of insulin, skeletal muscles and adipocytes, with the help of glucose transporter type 4, they uptake glucose from the blood. Okay, they uptake the glucose from the blood. So insulin is helping in the production of glucose transporter type 4. With the help of glucose transporter type 4, these tissues, skeletal muscle as well as adipocytes, they uptake the glucose from blood. So what kind of transport is this? Insulin is helping in the glucose transport into the cells. What kind of transport? Is it an active transport or a passive transport? Yes, it's a passive transport. It is an example of facilitated diffusion. In your exam, they will ask you, which of the following glucose transporters are insulin dependent? GLUT4. GLUT4 is insulin dependent. Where is this present? It is present on the skeletal muscles and adipocytes. Okay, done. Prothrombin to thrombin conversion needs which of the following? Prothrombin to thrombin conversion. You know, prothrombin is inactive factor number 2. It is inactive. Inactive factor number 2. Thrombin is active. So here what they are talking about is activation of the clotting factors. Activation ke liye, for the activation of the clotting factors, what do you require? You require calcium. Okay, you require calcium. Calcium is factor number 4. It is the clotting factor number 4. So that's why you look at this image. See, prothrombin is inactive. It is getting converted into active form. Once it is activated, what this thrombin will do? Thrombin will help in the conversion of fibrinogen into fibrin. So fibrin forms the clot. That's it. Fibrin forms the clot. The point is, for this activation, what do you require? Calcium. So activation of clotting factors require calcium and also phospholipids and a bunch other things are there, but I don't want you to remember. So activation requires calcium and phospholipids. Calcium and phospholipids are required for the activation. Okay. Even in this image, you can say prothrombin to thrombin conversion, what do you require? Calcium. In the activation of all the clotting factors, See, what do you require? Calcium, calcium, calcium here. So everywhere calcium is required for the activation of clotting factors. Okay. Now, one more point which I want you to know is regarding the magnesium. Okay. So if you are having low levels of magnesium in your body, that is hypomagnesemia. Okay, hypomagnesemia. If you are having less levels of magnesium in your body, which hormone levels goes down? Okay, which hormone levels goes down? The parathyroid hormone levels goes down. Okay, remember this, very important. So if a patient is having hypomagnesemia, the parathyroid hormone levels goes down. This is same. Okay, this is we have also discussed in the Gitelman syndrome. Gitelman syndrome. In Gitelman syndrome, the patient is going to have hypomagnesemia. Severe hypomagnesemia is seen. When there is severe hypomagnesemia, automatically parathyroid hormone levels decreases. When parathyroid hormone is less means, what happened to the blood levels of calcium? Blood levels of calcium also decrease. Without parathyroid hormone, no calcium. Parathyroid hormone regulates the calcium levels. No parathyroid hormone, no calcium levels. Okay, so what is important endocrine point which I want you to know? So magnesium, if it is not there, no parathyroid hormone. No parathyroid hormone means no calcium. Okay, so important point. Next, which of the following clotting factors would have decreased? Okay, gamma carboxyglutamate residue. Okay, in the patient on warfarin therapy. Okay, it's very straightforward question. We have also discussed this in the cardiovascular rapid revision. There I have explained you, if you take warfarin, what is it? It's an anti-clotting drug. Anti-clotting. It's anti-clotting. Okay. Now when you take warfarin, what exactly happens? Warfarin inhibits vitamin K epoxy reductase. This vitamin K epoxy reductase will be inhibited in the liver. So when this enzyme is inhibited, vitamin K epoxy reductase, now you won't have the reduced form of vitamin K. If you want to have reduced form of vitamin K, this should be functioning. Okay, this enzyme, it need to function. This enzyme need to function to have the reduced vitamin K, which is good. Okay, reduced vitamin K, because reduced vitamin K, it causes the gamma carboxylation of, it helps in the gamma carboxylation of factor number 2, 7, 9, 10. Gamma carboxylation of factor number 2, 7, 9, 10. The moment you take warfarin, what happens? This vitamin K epoxy reductase is inhibited, reduced vitamin K is not available. So gamma carboxylation of factor number 2, 7, 9, 10 and protein C and protein S. Not only them, protein C and protein S, anti-clotting proteins. So protein C and protein S, they are also not gamma carboxylated. Actually, this reduced form of vitamin K, it will help in the gamma carboxylation of factor number 2, 7, 9, 10 and protein C and protein S. Now, no vitamin K, no gamma carboxylation. So factor number 2 is not going to have gamma carboxyglutamate residue. It's not going to be seen. Okay. Just now I have explained you what this vitamin K will do. Vitamin K causes gamma carboxylation of factor number 2, 7, 9, 10. Okay. Which of the following is not a calcium binding protein? Okay. See, already I have explained you some important points about the calcium. Which secondary messenger increases the calcium levels? IP3. It increases the calcium levels within the cell. Okay, it increases the calcium levels within the cell. Then who binds with this calcium? See, let me write troponin binds with calcium. Troponin binds with the calcium, especially troponin C in the skeletal muscle contraction. Troponin C binds with the calcium. Calmodulin binds with the calcium. Okay, troponin, calmodulin. Next, calsequestrin. In the sarcoendoplasmic reticulum, calsequestrin and calreticulin. Okay, troponin, calmodulin, calsequestrin, calreticulin, calmodulin, calbindin. See, here I gave you a list. Okay, these are the proteins which binds with calcium. Okay, they actually bind with the calcium. Okay, troponin, calmodulin, calsequestrin, calreticulin, calbindin, all these fellows, they binds with calcium. but not the clatharins. Okay, clatharins are not the calcium binding proteins. Okay, they are not the calcium binding proteins. Now, which of the following ion plays an important role in exocytosis? See, exocytosis means the movement of substances out of the cell. Okay, the movement of substances out of the cell, exocytosis. For exocytosis, you require calcium. Okay, so calcium is, see, so many places calcium is coming. It helps in exocytosis. It helps in the activation of clotting factors. Okay, so many places. Now, calcium, look, is helping in exocytosis, okay. But for exocytosis, what others are needed? Even in general physiology, I have explained you what other proteins are needed for exocytosis. Snare proteins are needed for exocytosis. I have gave the mnemonic also, snare. It looks like snake. Okay, snare, something like snake. So who is a snake? X, your X is a snake. Something like that. Okay, so for exocytosis, what are required? Which proteins are required? Snare proteins are required, as well as calcium is required. Next, which of the following hormone regulate the blood levels of vitamin D? Okay, blood levels of vitamin D. For this purpose, I have to teach you the vitamin D activation. Look, here is the sun. Let's say here is the sun. Now sun is producing which rays? UVB rays. Now when this UVB rays, when they are falling on your skin, okay, when they are falling on your skin, the cholesterol, the 7-dehydroxycholesterol which is present under your skin, okay, there will be cholesterol under your skin. So 7, this is there under your skin. Now by taking this sun rays, okay, by taking this sun rays, the 7-dehydroxycholesterol will be converted into cholecalciferol. It will be converted into cholecalciferol. Now this cholecalciferol, okay, it will go to the liver. Now in the liver, this cholecalciferol will be hydroxylated. Okay, one hydroxy group will be added. So that becomes 25 hydroxy cholecalciferol. Now this 25 hydroxy cholecalciferol, now it will go to the kidneys. In the kidneys where? In the kidneys nephrons. So which part of the nephron? In the proximal convoluted tubule. So in the proximal convoluted tubule, this 25 hydroxy cholecalciferol will be converted into 1,25 dihydroxy cholecalciferol, which is also called as calcitriol. So why this activation? This is the active vitamin D. Active vitamin D. So why is this activation happening in the PCT only? Why is this activation only happening in the PCT? Because in the PCT there is necessary enzyme that is called as alpha-1 hydroxylase. Okay, alpha-1 hydroxy, OH means hydroxylase, okay, in the short form, alpha-1 hydroxylase. So with the help of this enzyme called as alpha-1 hydroxylase, 25 hydroxy cholecalciferol will be converted into 1,25 dihydroxy cholecalciferol. Okay, 1,25, this is 25, 1,25 dihydroxy cholecalciferol, which is also called as calcitriol. Now my question to you, sir, this alpha-1 hydroxylase activity, it is under the control of which hormone? It is under the control of parathyroid hormone. So it's a parathyroid hormone tells. It's a parathyroid hormone tells alpha-1 hydroxylase when to function, when not to function. So for example, say the patient is having hypocalcemia. Okay, the blood calcium levels are going down. So when the blood calcium levels are going down, what happens? That will be detected by the parathyroid glands. Parathyroid glands detect there is hypocalcemia, which is bad. So parathyroid glands immediately release parathyroid hormone. So what is this parathyroid hormone doing? The parathyroid hormone now acts on or activates alpha-1 hydroxylase. Now the alpha-1 hydroxylase is going to convert this inactive vitamin D, that is 25 hydroxy cholecalciferol, into 1,25 dihydroxy cholecalciferol active form. So that is called as calcitriol. So what is calcitriol is going to do? The calcitriol is going to act on your GIT, helps in absorption of calcium and phosphates. Both important. Both calcium and phosphates will be absorbed. Okay. So now tell me, based on this, the activation of vitamin D, the calcitriol. See, this is the active form of vitamin D, the calcitriol, 1,25 dihydroxy cholecalciferol. Where is it happening? In the PCT MCQ. Why in the PCT? Because alpha-1 hydroxylase is present in the PCT. The alpha-1 hydroxylase, it is under the control of which hormone? Parathyroid hormone. So hydroxylation is happening in which organs? One is the liver. First hydroxylation happened in the liver, and the final hydroxylation occurs in kidneys. Okay, so based on this, tell me which of the following hormones regulate the blood levels of vitamin D? Parathyroid hormone. Okay, parathyroid hormone. Now, I have told you already, parathyroid hormone function is what? It increases the blood levels of calcium. Parathyroid hormone increases the blood levels of calcium. How it increases the blood levels of calcium? By activating vitamin D. Okay, so I can say something like this. So parathyroid hormone, look here, parathyroid hormone, one thing, what it is doing, it activates vitamin D. So by activating vitamin D, it increases the blood levels of calcium. The parathyroid hormone also act on distal convoluted tubule. Distal convoluted tubule, DCT. So if it is acting on the DCT, it increases calcium reabsorption. The parathyroid hormone also acts on PCT, decreases phosphate reabsorption. Okay, decrease the phosphate reabsorption. So more and more phosphate will be excreted out. More and more phosphates will be excreted out. So these are some important points regarding the parathyroid hormone. Okay. Now, adrenal medulla secretes. Adrenal medulla. So you know, look here, here is adrenal gland. This is the adrenal medulla. The adrenal cortex. Look, adrenal cortex. It is having three zones. That is zona glomerulosa, zona fasciculata, and this innermost zona reticularis. Okay, let me write here. Let me write this one, this area, zona reticularis. Now, the points which I want you to know is the zona glomerulosa. You know, zona glomerulosa produces aldosterone, which is a mineralocorticoid. It's a mineralocorticoid MC. Okay, mineralocorticoid. Zona fasciculata. Okay, zona fasciculata, it produces cortisol. It's a glucocorticoid, GC, glucocorticoid. And zona reticularis. Zona reticularis, it produces dihydroepiandrosterone sulfate, DHEAS, also androstenedione, androstenedione. So these are sex corticoids. Okay, these are adrenal androgens. These are adrenal androgens. Okay, these are the adrenal androgens. So this was the question. Adrenal cortex exclusively secretes, or this one, dihydroepiandrosterone sulfate, is exclusively secreted from adrenal gland. Okay, it's exclusively secreted from adrenal gland. Anyway, adrenal cortex is divided into glomerulosa, fasciculata, and reticularis, GFR. Mineralocorticoids are produced from glomerulosa, cortisol is produced from fasciculata, and reticularis produces androgens. That everyone knows. Now here, the adrenal medulla. Okay, the adrenal medulla, it contains these cells. Okay, it contains these cells. These cells which are there in the adrenal medulla, these are called as chromaffin cells. Chromaffin cells. Now these chromaffin cells, what do they produce? Adrenal medulla produces adrenaline, noradrenaline. So adrenaline, also called as epinephrine, noradrenaline. Okay, so the answer is the adrenal medulla. They are talking about adrenal medulla. It secretes adrenaline. Okay, adrenaline, also called as epinephrine. My question to you, epinephrine, is it a neurotransmitter or not? Yes, these are neurotransmitters. These are neurotransmitters. Then how come neurotransmitters are getting produced from the adrenal medulla? How these neurotransmitters are coming from the adrenal medulla? Something to do with the embryology. See, these chromaffin cells at the adrenal medulla, it's derived from where? Neural crest cells. Okay, they are derivatives of neural crest cells, so that's why they are producing the neurotransmitters. Okay, see, if there is a tumor here in the adrenal medulla, if there is a tumor, Okay, if there is a tumor, so that tumor is called as tumor of adrenal medulla. It's called as pheochromocytoma. Okay, so the tumor of adrenal medulla is called as a pheochromocytoma. Now tell me, pheochromocytomas are associated with which syndrome? Pheochromocytomas are associated with MEN2. Okay, so pheochromocytoma is associated with MEN2 syndrome. Important MCQ. Okay, a few more important points. If a patient is having pheochromocytoma, let me write here. If a patient is having pheochromocytoma, okay, the tumor of adrenal medulla, pheochromocytoma. Okay, so there will be more adrenaline production in the body. These adrenaline, look carefully, these adrenaline will be broken down. Okay, these adrenaline will be broken down into metabolites. So look here, the adrenaline will be converted into metanephrines. Okay, the adrenaline will be converted into metanephrines and they will be excreted in the urine. So the metabolites of adrenaline, noradrenaline, they are metanephrines and vinyl mandelic acid. See, what are these things? See, if a patient is having pheochromocytoma, there is a tumor in the adrenal medulla, so they are producing more amount of adrenaline, noradrenaline. So the breakdown products of this adrenaline, noradrenaline are vinyl mandelic acid and metanephrines, mainly metanephrine. So what happens to the urine levels of these compounds? The urine levels of these metanephrines are going to increase. So if you see this thing, a question, a very big clinical case where they are saying the urinary levels of vinyl mandelic acid and metanephrines are elevated. So you have to think about a tumor in adrenal medulla, tumor of chromaffin cells. What if there is a tumor here? See, already I have discussed with you, if there is a tumor here in the adrenal medulla, that is called as pheochromocytoma. What if there is a tumor here in the adrenal cortex? There is a tumor in the adrenal cortex that is called as adrenal adenoma. Okay, adrenal adenoma. What is this adrenal adenoma producing? It produces excessive amount of adrenaline? No, it produces excessive amount of aldosterone. Okay, it produces excessive amount of aldosterone. Now tell me, what is the function of aldosterone? Normal, let me tell you, let me write here. Say, normal aldosterone function, normal functions. Now aldosterone, it increases sodium reabsorption. Okay, this is a normal function. But in our condition, see, there is adrenal adenoma, there is more aldosterone there in the body. More aldosterone is there in the body because of this tumor, So more aldosterone means more sodium reabsorption. So the body levels of sodium increase and this patient is going to have hypertension. These patients are going to have hypertension because of hypernatremia. There is hypernatremia. Next, normal function of aldosterone is aldosterone. Okay, aldosterone is going to cause potassium excretion. Okay, potassium excretion. Now here, more potassium will be excreted out. So what happened to the body levels of potassium? Body levels of potassium decreases. So that's going to cause hypokalemia. Okay. Next, aldosterone kicks the protons out of the body. Proton excretion. Protons, acids are going out. So what happened to the body levels of protons? Body levels of acids, they decreases. So when the acids are decreasing in the body, that will cause alkalosis. Okay, alkalosis in the body. So this condition, patient is having adrenal adenoma, the aldosterone levels are going to rise up because of the hyperaldosteronism. Okay, because of this hyperaldosteronism, the patient is going to have hypertension with the hypokalemic metabolic alkalosis. Okay, hypertension with hypokalemic metabolic alkalosis. So this syndrome is called as Conn syndrome. Okay, it's called as Conn syndrome. So these are the points which I want you to know regarding pheochromocytoma, which is associated with MEN type 2 and Conn syndrome, that is hyperaldosteronism. Okay, so these are some important points. So finally tell me, from your adrenal gland, if you look at here, adrenal gland, who are coming? Sir, zona glomerulosa say from the zona glomerulosa aldosterone is coming, zona fasciculata is producing the cortisol and zona reticularis that is producing the sex corticoids. So all these adrenal hormones, let me write here, adrenal hormones which are coming from the cortex, all are steroid hormones. That's aldosterone, mineralocorticoid, glucocorticoid and sex corticoids, all are steroid hormones. So what are steroid hormones? What exactly does it mean by steroid? Steroid hormones means all these are derivatives of cholesterol. Okay, they are all derivatives of cholesterol. So if they are derivatives of cholesterol means these are cholesterol derived hormones. So they can cross the cell membrane or not. Cell membrane is a phospholipid layer and these hormones are cholesterol derivatives. So like things, both are like things. So these steroid hormones, they cross the cell membrane. So do you think these hormones have cell surface receptors or intracellular receptors? So these all hormones, whatever I have discussed, aldosterone, cortisol, okay, sex hormones, they have receptors within the cell. So they have intracellular receptors. Okay, they have intracellular receptors. Maybe that intracellular receptor may be intracytoplasmic, means within the cytoplasm for aldosterone and cortisol, or it may be intranuclear, means within the nucleus, okay. So already you know, sir, I have explained to you intranuclear receptors are there for thyroid hormones. Thyroid hormones have intranuclear receptors. Now this important point which I want you to know is aldosterone. Aldosterone have intracytoplasmic receptor. Aldosterone is having intracytoplasmic receptor. Okay, done. Now insulin like growth factor, it is produced by which of the following organ? First of all, what is this insulin like growth factor? It's a very simple thing. Look, here is a hypothalamus, here is anterior pituitary. Now look, the hypothalamic nucleus is producing growth hormone releasing hormone. Okay, growth hormone releasing hormone. This growth hormone releasing hormone comes and acts on somatotropes. So the somatotropes are going to produce growth hormone. Growth hormone causes elongation of bone length, protein synthesis, lipolysis, increase the blood glucose levels, okay, decrease the insulin sensitivity, so many things. Growth hormone, once you have sufficient amount of growth hormone, look what is happening to this growth hormone. Growth hormone goes and acts on liver. Okay, growth hormone is going and acting on the liver. Its receptors are also there on the liver. Now when the growth hormone is acting on the liver secretes insulin like growth factor, also called as somatomedian C. Now this insulin like growth factor, somatomedian C, it gives a negative feedback. Okay, negative feedback. So tell me, insulin like growth factor is produced by which of the following organ? Produced by liver. Okay. Next, which of the following is the most potent stimulator of aldosterone secretion? Guys, already I have explained you. For the release of antidiuretic hormone, what is the stimulus for the release of antidiuretic hormone? The stimulus for the release of the antidiuretic hormone is hypertonic plasma. So hypertonic plasma is going to stimulate the subcortical organ masculosum, releases antidiuretic hormone. So what is the stimulus for the release of aldosterone? It's not the BP, it's not the low BP, it is hyperkalemia. The answer is hyperkalemia. Okay, hyperkalemia, that is more potassium. How much more potassium? Potassium more than 5.5 milli equivalents per liter. Okay, if you have this much amount of potassium, that's going to cause hyperkalemia, and hyperkalemia is a very bad thing that can trigger the arrhythmias. So hyperkalemia is going to stimulate the release of aldosterone. Why? Because you know what is the function of aldosterone? Aldosterone causes potassium excretion out of the body. Okay, aldosterone causes potassium excretion out of the body. So by doing the potassium excretion, it can decreases the potassium levels in the body. Okay. That's the one thing. Next, feed forward control mechanism is employed during the regulation of. See, feed forward control means, what does it mean by feed forward control? Let me tell you. For example, you are just thinking, you are not even doing, it came to your mind that you just want to do the exercise. Immediately what happens is your respiratory rate increases. For example, look, for some examples of feed forward control. Okay, you know about the feedback. Feedback, when you have sufficient amount of hormones, these hormones are going to give the negative feedback. Okay, so that releasing hormones should go down. So what is feed forward? You are anticipating, okay, I am going to do the exercise. Okay, I am going to do something. Okay, I am going to eat. The moment you think that you are going to eat, acid production started. Means your body is making your, making everything ready. You are thinking about eating. Your GIT is producing the acid. Something like that. See, allows the body to anticipate the change and maintain the homeostasis or stability. For example, say, watering of mouth, that is salivation, as a result of thinking about the food or thought of food, immediately your body is getting ready, salivation happened. So salivation, this is an example of feed forward mechanism. Okay, raise in body temperature before exercise. Now, you are not even doing, you are thinking. Okay, so body temperature raises. Increase secretion of insulin as a result of presence of food. You have taken the food. Okay, you have taken the food. Immediately, if you take the food, your insulin, your blood glucose levels are not yet raised. Your blood glucose levels are not yet raised. You take the food is still in the stomach. Your pancreas will start to release the insulin. Okay, so this is all example of, these are all examples of feed forward control. They are all helping to maintain the stability in the body. Okay, for example, say you take food, blood glucose levels. If insulin is not released, what happens? If insulin is not released, it means there will be hyperglycemia, and that's bad thing. Okay, so which of the following is an example of a feed forward regulation? Remember, temperature. Okay, temperature will increase. Okay, when you think about the exercise, the body temperature increases. It's an example of a feed forward mechanism, feed forward control mechanism. Now, the last thing which I want to explain here in endocrine is the last hormone, that is insulin. Okay, insulin. Insulin, it's a peptide hormone. Okay, from where this insulin is getting produced? Insulin is produced from the beta cells of the pancreas. You know it. Along with insulin, this beta cells, see, beta cells produce insulin, no doubt, insulin. Okay, along with insulin, one more substance is produced that is called as a C-peptide. Also one more hormone, that is amylin. Okay, so your beta cells are producing the insulin. Three things are getting produced. Your beta cells, they are making insulin, C-peptide as well as amylin. Insulin is stored with, okay, insulin is stored with which ions? Zinc ions. Okay, zinc ions, because zinc gives stability to structure of insulin. Zinc is the one which gives the stability to the structure of the insulin. See, for example, if one insulin molecule is produced, okay, one insulin molecule is released from the beta cell of the pancreas. Insulin is having very short half-life. Okay, you can't measure the insulin levels directly, because when insulin is going to be released, and you can't get the exact value of how much insulin is getting released, because insulin is having very short half-life. How to know insulin levels is, say, for example, let's say if one insulin molecule is released, one C-peptide molecule will be released, but the C-peptide is biologically inactive. Okay, it's not going to be metabolized, it will simply come out of the body. So the point which I want you to know is, if one insulin is released, how many C-peptides are released? 1. If 100 insulins are released, 100 C-peptides will be there. But you can't see the insulin in the blood because it is rapidly metabolized. But you can see the C-peptide. So the points are, the C-peptide is produced in equimolar concentration along with insulin. It's produced in equimolar concentration along with insulin. So by you looking at the C-peptide number, you can estimate how much insulin is produced. So it's a marker of endogenous insulin production. It's a marker of endogenous insulin production. Okay, so what insulin will do? Already I have explained you. Insulin for number one function. Okay, insulin number one function is it decreases the blood glucose levels by production of which channels? By the production of glucose transporter type 4. With the help of the glucose transporter type 4. Now, whenever there is insulin, okay, let me write here. Whenever there is insulin, let me just erase and write so you will have a clarity. So first insulin is released. So what happens whenever there is insulin? Insulin stimulates its tyrosine kinase receptor. When this receptor is activated, now the cells, which cells? Now the skeletal cells as well as the adipocytes, they will uptake the glucose with the help of glucose transporter type 4. With the help of the glucose transporter type 4, they absorb the glucose. From where? From blood. So by doing this, they decrease the blood levels of glucose. So the glucose is moving from the blood into the tissues. Okay, that's okay. That everyone will say. This is the normal function of the insulin. But one more function of insulin is insulin moves potassium into the cells. So if you inject insulin, they will ask you what happened to the potassium. What kind of changes will happen to the potassium? Potassium will move into the cells. Okay, the adipocytes, they will take up all the potassium. Okay. Next, what else regarding the biochemistry? What insulin will do? Say, let me write here, insulin. Insulin goal is one thing. Okay, insulin goal is one. They want to decrease the blood glucose levels. One way you know it, by production of the glucose transporter type 4, it decreases the blood glucose levels. No doubt in that. What else it will do is those biochemical reactions which decreases the blood glucose levels, they will be activated. For example, say glycogen synthesis. So the glycogen synthesis, you know what is glycogen synthesis? Taking the glucose, converting into glycogen. Okay, glycogenesis or glycogen synthesis. Taking the glucose, removing the glucose from the blood, converting into glycogen in the liver with the help of glycogen synthase enzyme, branching enzyme, right, branching enzyme, alpha 1,4 bonds, alpha 1,6 bonds, the biochemistry thing. So what insulin is doing? Insulin is going to activate those enzymes which are required for glycogen synthesis. So if there is glycogen synthesis, what happened to blood glucose levels? Decrease. Okay. Next, activates lipogenesis. Okay, lipogenesis. What is lipogenesis? Taking the glucose, converting into the fatty acids. So you are taking, when you are having sufficient amount of glucose, the glucose will be converted into fatty acids. So what happened to the blood glucose levels? Blood glucose levels decreases. Okay. Now insulin, what it is doing? It is activating. See, I am keeping the plus symbols here, which means activation. There is activation of glycolysis. Glycolysis. What is glycolysis? Glycolysis means taking the glucose from the blood. Taking the glucose from the blood, the glucose will be utilized for the production of ATP. Okay, the glucose will be utilized for the production of ATP. So you are removing the glucose and using it for the production of ATP. So all these reactions, glycogen synthesis, lipogenesis and glycolysis, they all decrease the blood glucose levels. So they are activated. So insulin activates which biochemical reactions? I gave a list. And those biochemical reactions, those biochemical reactions which increases the blood glucose levels, they will be inhibited. What are they? Glycogenolysis. Glycogen is getting broken down. That is inhibited. We don't want that because it increases the blood glucose level. So it is inhibited. And what else is inhibited? Gluconeogenesis. So gluconeogenesis, what exactly gluconeogenesis is going to do? The name itself is there, newly genesis. Newly glucose is forming. So that will also be inhibited because it increases the blood glucose levels. What else? See, apart from this, the ketones and lipids. See, for example, I have told you, just look here. Till the time insulin is present in the body, there will be lipogenesis. So till the time insulin is there in the body, there won't be lipolysis. So it inhibits lipolysis. It inhibits the lipolysis, and also it inhibits ketogenesis. Okay, ketogenesis or ketone body formation. So now you can say, in diabetes mellitus patient, in a patient who is having diabetes mellitus, for example type 1 diabetes mellitus, there is no insulin. Okay, there is no insulin. If insulin is not there, what happens? There will be ketogenesis. Okay, there will be ketogenesis, ketone body synthesis. So because of this ketogenesis, there will be diabetic, the patient is having diabetic ketoacidosis. Ketone bodies are acids. Ketone bodies are acids. That's why it's an integration. If you don't have this insulin, okay, if you don't have this insulin, now ketogenesis is not inhibited. Insulin inhibits ketogenesis. If insulin is not there, means in type 1 diabetes mellitus, insulinopenia. Okay, insulinopenia, insulin is not there. So there will be ketogenesis, ketone body formation. That ketone bodies are going to cause acidosis. Ketone bodies are acids. Okay, acetone, acetoacetic acid, beta hydroxybutyric acid. These are all ketone bodies. They all leads to acidosis. Okay, diabetic ketoacidosis. So in this slide, what I have explained you, important functions of the insulin, some important functions of the insulin which I want you to know for your exam. Okay, so with this we have discussed the previously asked questions in the exam, and also we have discussed important points which you need to know, okay, before going to the exam. Hope the video is helpful. Thank you.